Okay, good afternoon. In the interest of trying to get on time, we'll get started, okay? And there's plenty of time built in for questions as well. So I'm Brian Cole from Chicago, and I want to thank Tom and Andreas and the institution for putting together this course with its focus. It's always interesting, and it's great to see old friends. So let me, if you could switch over, that'd be great. Okay. So Tom, I think, asked me to do this because he knows I can speak the fastest of anyone to cover a broad topic. So what I'd like to do is just, I'll stay pretty focused and really try to offer practical considerations when you're deciding how to use various technologies in the decision-making for managing problems, specifically for the knee. I think the first premise is that we really need to consider before we treat lesions. To the extent that many of these lesions are incidental, the incidence is quite high in all comers, especially those over age 40. And we've seen in various populations of patients excellent results with benign neglect. And the flip side is that there are lesions that show up, for example, at the time of, say, ACL reconstruction that get treated, and we don't know that those are truly symptomatic because we often find them at the time of reconstruction, yet there's some literature that supports that they don't do well long term. So I think we pull the trigger for treatment when we really believe that it's required, so a relevant defect consistent with the symptoms. One of the other real challenges that faces most of us in the clinic setting is, why do people hurt? I show this video because it's a patient who underwent a marrow stimulation procedure, and she has pretty decent fill. And you look at the size of that defect relative to the size of the femoral condyle, and you could take that same defect, place it from a female into a male, and it occupies much less surface area relative to that weight-bearing condyle. So most symptoms are really load-related when you think about it. So the other comorbidities, such as meniscal deficiency, really add to increasing load, malalignment, BMI, activity levels, all of those speak to the extent that load actually elicits symptoms in these patients, and if they can more effectively share load, they may do better. So it's not just the absolute defect size. That's a really limited way to consider decision-making challenges. These are the things that I think about. What is the least amount we can do to make someone better? What will provide the fastest recovery? What will endure the sport and the loads imposed? What will keep them out of the operating room again and not burn bridges for future treatments, as many of these patients unfortunately end up getting subsequent treatments. And whenever possible, especially for really active patients, I'm looking for an isolated extra-articular option, or I'm looking for an option that will endure high levels of sports, cutting, pivoting, and things of that nature. So this is the current landscape as it exists in the United States, and it's sort of an inverse relationship between what we think is tissue durability as well as ease and resource intensity. And all of these procedures differ in frequency. You know, debridement probably is 300,000 times, 400,000 times a year. Marrow stimulation is probably at least 100,000 times a year, and then they subsequently decrease, as you see here, linearly. This is the one slide that basically takes into consideration how I currently think about these various options. So I do use debridement liberally, especially for my very active patient population. Marrow stimulation is still a consideration for me for smaller lesions, and I may add something such as biocartilage or some other adjunct to improve upon the results of marrow stimulation. Osteochondral autografts for that rare small lesion that's causing pain, especially as revision treatment following marrow stimulation. ACI still is in the algorithm for me for patellofemoral or larger lesions when the bone is not particularly involved. There are a number of surface options that are available. Most commonly, we would use those just because of architectural considerations in the patellofemoral joint. But largely, at least in Chicago, where I have access to grafts, osteochondral allografts is, and especially because I have a revision population, and my most common transplant now is a patient who has both femoral disease and is meniscectomized. So OA grafts have become pretty much the mainstream, just largely because of the population that I see. There are some advantages to debridement, and it probably starts with the concept of creating a vertical wall. And what we know from, this is some 3D micro-CT evaluation of what happens when you create a vertical wall in a defect. And essentially what happens is it just makes the defect less relevant. So if you think about OCD on the lateral aspect of the medial femoral condyle, once you remove that piece, it's incredibly well tolerated. They present with symptoms, usually because of the loose body. Remove that piece, and then on the upslope of the lateral side of the medial femoral condyle, the natural history is actually pretty decent. Lateral side may have a different story, but those patients often feel better right when you remove the piece. And that's probably because the defect is actually shielded and the surrounding areas are doing a good job of tolerating load. So again, I think it all goes back to load much more so than even biology. We've looked at our patients who we slated to undergo ACI in the past, and it was interesting that in this particular timeline that 44% of our patients who we intended to implant were not implanted, and 60% of those responded with pain relief just from their debridement. So debridement is a very real consideration, especially if you take care of high-level athletes or those people who don't have the time to recover for maybe longer-term outcomes. This is one of those individuals. So this is an individual who can play but has swelling, compromise in their performance. Injection helped initially. They're still in season and has 1 year left until free agency. And when you look at that MRI, and there's even a suggestion on X-ray, you say that is a really ominous problem. How are we going to get this patient better? And at the time of arthroscopy, this is what we found. And clearly the zone of injury is much bigger than what you see here arthroscopically, right? And all we did was to debride that piece. And he's actually now, I have him out at, he's actually 4 years now still with a veteran contract. So the point is that debridement could be a viable option, and they may get better just because you're getting rid of that noxious stimuli from having that unstable flap, maybe getting rid of some of the biologic debris and so forth, but they get to a situation from a symptomatic to an asymptomatic state with something very simple. What about marrostimulation? There's clearly more controversy now surrounding marrostimulation, but there's very good literature, even level 1 literature, that supports marrostimulation, and I'll talk about this in the afternoon in the video vignette. But even high-level athletes, as long as they meet certain criteria, can do well with marrostimulation. Another similar type example, this is a female basketball player. She's had lateral-sided knee pain. She is slated to come out for the WNBA as a draft pick, but still in college, and is deciding, does she have the time off to get treated now in preparation for the draft, or should she continue to play? And she just can't play. So she comes to surgery, and she has a very small, I would say, incidental lateral meniscal problem. I don't think that would make her better. She had a small defect and a loose body. And she wasn't complaining of mechanical symptoms, but she was complaining of weight-bearing pain and swelling. So I had to make a decision here. A very small defect, probably could treat this with nothing, marrostimulation, or maybe an osteochondral autograft. And the thing that tipped me to treating this with marrostimulation was because she had weight-bearing pain, achiness, and swelling and wasn't complaining of mechanical symptoms. I didn't think debridement would be enough for her. But you could have said, why not do an autograft? And I wouldn't argue with that. But the issue is the tempo of her recovery. It took her 8 months before she actually felt well enough to return to play. We tried it 4 months, wasn't good enough. Tried it 6 months, wasn't good enough. Finally, by 8 months, she felt well enough to do so. So one would argue that debridement wasn't enough for her, because if it was, in 2, 3, 4 weeks, she might have felt better. But she needed this much time to derive whatever tissue would regenerate with marrostimulation to get back. As I mentioned, osteochondral autograft is a good solution, and the literature that's compared to marrostimulation is actually quite favorable. The challenge with this population, in my experience, is that it's actually pretty rare where you come across an isolated small defect where you can use a single plug, which is my preference, and they have symptoms that require treatment. So I use this for revision of very small defects, for incidental lesions when I'm doing a meniscal allograft and things like that. But I just don't see the clinical population of people with very small defects that require treatment of any kind. So for very small, out-of-the-box, low morbidity, I still stick with marrostimulation. This is usually reserved for people who fail marrostimulation who still have 11, 12 millimeter defects or smaller. ACI still has an excellent track record. You heard a wonderful talk on that, so I don't want to go into any greater detail. Suffice it to say that if you look at very athletic population of patients, they too can return to play within 8 to 12 months in excess of 75%. As I alluded to, osteochondral allograft is pretty much my go-to for revision situations, for scenarios where they're meniscectomized, for high-level athletes who are malaligned, where even if they're meniscectomized, maybe we'll say, let's not do the meniscus, because that's the first thing that's going to be compromised if they get back to sport, and hope that we are able to do enough, for example, with a realignment and an allograft. So this has been my go-to of recent. Very high-level individual, had already had treatment, including marrostimulation for 2 different areas of cartilage loss, and simply cannot play. And this one, as a revision, underwent both a trochlear and a femoral condyle lesion with an osteochondral allograft, and he actually was able to get back and played for another 2 years at an NBA level. But these are rare situations. We don't go into it saying, look, this is what we're trying to achieve. You hope that these individuals have problems with activities of daily living and beyond, and then the net advantage of getting back to high-level sport is icing on the cake. But it's rare that you make a decision in isolation that the only reason we're doing it is to get them back to high-level play. Osteochondral allograft in the tibial femoral joint, same type of outcomes that we're seeing in other series. fresh osteochondral allografts, 24 days or sooner, get patients back, return to sport in excess of 75% in most series. And even in the military population, which is very challenging, you can get there, but it seems to be a little more challenging in the military series compared to our series in a truly athletic population without that background noise of getting back to the military. There's now this sort of allograft frenzy, largely because the regulations are fairly simple in terms of allograft tissue getting to your hands as a clinician. So it's getting increasingly difficult to sort of sort out where you may use all of these, and maybe that we'll use that for some of the question and answer period. But there are a number of surface treatments, biocartilage, which is essentially an anhydrous form of allograft cartilage that we hydrate with either PRP or BMAC. Then there's minced cartilage, which can be autogeneic or allogeneic, like de novo NT. Then there are surface grafts like Cartiform, Prochondrix. I think I named the only two that are out there. I probably missed something. And then now we have the ability, due to instrumentation, to treat larger areas, the so-called biouni, larger areas of cartilage and bone involvement on the medial side. So this is something we sort of have to sort out in an algorithm. In the minced area, there's actually two series that have looked at this, but they're level 4 data. But you can achieve reasonably good results both by MRI and clinical outcomes, both in the patellofemoral joint as well as on the femoral side using minced juvenile tissue. This is a high-level, he's an Olympic wrestler who basically was out, could not wrestle, had failed prior to debridement, was unable to compete. One of our earlier athletes that we treated with this, he had tibial lesion that you see here that we did marrow stimulation, and it's sort of on the eminence, so maybe it's something that's relatively protected. And then had a lesion that we put a type 1-3 collagen membrane over de novo, and that was our, you could have offered him 3 or 4 different things at the time. This case was about 8 years ago, and he actually ended up getting back and competing. So I think the take home is lots of ways to get it right. I'm not sure I can stand up here and tell you which thing is going to work each time, but staying within the basic principles when the subchondral bone is or isn't involved, and most importantly, dealing with comorbidities is going to be really critical to your decision making. This is another, he's a lineman, so this guy's about 300 pounds, so the loads are very high, the sport loads are very high, years of medial pain, unable to continue playing. And this is, again, what's always fascinating is you look at the MRI, much larger zone of injury. If you just took this injury in the context of what you see arthroscopically, maybe you can do an osteochondral allograft, maybe you could do ACI, but there's a fair amount of bony involvement as you see on his MRI, so your decision making may vary based on that. And in this situation, we did marrow stimulation and biocartilage at the same time. And it was interesting, if you look at his follow-up MRI, actually had restoration with reduction of edema there and some type of healing response that seemed to be favorable, and actually was able to get back to a very high level within 6 months, and at 1 year was picked up by a team and is still playing. The clinical reality, however, is that these defects don't exist in isolation. So I think, as I started out saying, it's the comorbidities that really guide our decision making, and you could probably pick between 1 and 4 options to treat the cartilage problem and get it right, but not in the absence of addressing comorbidities. So situation, this is sort of the quintessential orthopedic home run. A young active woman comes in with a meniscal tear, intact articular cartilage along the top there, and 6 months later she returns back to high-level tennis, but recreational, and she deteriorates, and that's what her joint looked like at 6 months. So this will occasionally happen. Not every meniscectomy is going to get a good or excellent result, and she ended up getting both treatment of a meniscal deficient state as well as an allograft, and was able to get back. She'll say, look, I have no pain, but I feel achy on occasion, and she actually got back to fairly high-level running in distances. But the point is that a meniscectomy is not, as we all know, not always an innocuous procedure, and we have to address all the pathologies, meniscal deficiency and the chondral surface. Similarly in comparison to our cartilage procedures, our cumulative return to sport in the meniscal transplant population is actually much higher than we would have ever anticipated. So there's now 3 series, albeit all level 4, that are showing that the re-tear rates in this population is less than 20% in the first 3 years of getting a meniscal allograft. So it can be done, but it's certainly not the ideal scenario. And then finally, the last morbidity is really malalignment. And one of the things that we've been particularly interested in is we often speak about realignment procedures. not overcorrecting them in this population because they tend to be very young. And one of the questions we were interested in is saying, look, how much do you have to offload them for a medial disease, for example, until you get the biggest bang for your buck? And what we found is that if you just get them over to 3 degrees of valgus, that unloads, you get about 70% of your unloading portion of the operation. So anything beyond that, we didn't accrue significant increases in offloading on the medial side. So my general algorithm for osteotomy is if I can at least do a 5 to get them over to the other side, I'll do it. If a 5-degree correction or less isn't going to do it, I won't do it. And that's the same thing for the distal femur. I'm not going to waste my time if a 5 or less is required, generally speaking. So it has to be at least a 5, and I try to just get them to the opposite eminence when they're in varus. So this is one who is in valgus, gets a DFO, challenging population. He's meniscal deficient, and he has a focal defect, and he's in valgus, and he's going back, hopefully, to high-level soccer. How's it going to happen? My feeling is if you're going to send a guy like this back with a meniscal allograft, probably too much opportunity for him to disrupt that meniscal tissue. And if you think you can get it right by doing less and leaving the meniscus out of the equation, especially in the setting of a realignment opportunity, I would do the realignment, do an allograft or whatever your cartilage choice is, and kind of hope for the best. And if it's not enough pain relief, you can, in theory, come back and do meniscus. But an operation like this can get them back in 4 to 6 months, as opposed to probably a bit longer if you're using a meniscal allograft on top of it. So the lowest hanging fruit is the opportunity to do an osteotomy. And there's actually pretty decent data when you look at osteotomy alone and getting an individual back to high-level sport. And that's both in the military population and the high-level athlete population. So it can be done, and then dealing with the cartilage problem is sort of icing on the cake. Okay, and just a couple of slides on patellofemoral joint, because I think you covered it in the next section, but I was asked to just speak about cartilage procedures here. The challenge in the patellofemoral joint is that pain, chondrosis, and instability can be either interdependent or completely unrelated. So you have to ask a lot of questions of these patients to decide how you're going to treat each of these issues. And as an overview, we've got to get the correct diagnosis. And many of these patients will do well with non-operative treatment, which includes weight loss, by the way, and it includes education, that they should try to coexist with their disease, because our results in the patellofemoral joint tend to be a little more challenging given this disconnect between alignment, BMI, load, and so forth. I use debridement frequently as an index treatment for the patellofemoral joint if they have failed maximized non-operative treatment. We respect our objective measurements to the best of our ability so that we don't overcorrect them when we include a TTO. And my general treatment pathway is for small lesions, I use marrow stimulation or maybe surface allografts. For larger lesions, I'll consider cell-based techniques or an osteochondral graft. And all of our revision techniques get an osteochondral graft. So one question that gets asked is, look, is an AMZ or a TTO enough? And I would say it may be enough in patients who don't have a lot of effusions and achiness and so forth, who really just have load pain if their problem is inferolateral. Those patients actually may do very well with an isolated tibiotubercle osteotomy. Everyone else becomes a particular challenge, even in the absence of sort of that barometric pain, achiness, and sort of a wet synovitis or joint. So if it's a load problem, you can treat it with an unloading procedure. This isn't a realignment procedure in my mind, it's an unloading procedure. So to that point, the tibiotubercle osteotomy, we sort of gauge how far we go up and over based upon these preoperative measurements. And many of these patients are normally aligned. And they say, well, they're not malaligned, why would I do a TTO? Because it might offer some additional benefit, just like an HTO or a DFO does in unloading the joint. But if you don't have much room to move medially, you can still use that McKay concept to move them anteriorly. And if you're uncomfortable doing a McKay, this is a study that we did a couple of years ago that said, look, if you just bring them forward, similar to McKay, but do your tibiotubercle osteotomy sort of as Fulkerson described, but go front to back, sparing the posterior cortex, you can achieve 30 to 40% unloading across the joint without medializing them at all, and it's still a very technically safe operation to do. So just give you 3 scenarios that you're likely to see. One is incidental pathology. I typically see it more in the trochlea than the patella. These are degenerative lesions. These are the ones we rehabilitate and we observe, and I don't offer treatment. What about the acute patella dislocation? Well, the pathology here is an MPFL disruption, either off the patella or the femur. And they often intra-articularly will have a medial patella lesion and a lateral trochlear lesion. We will try to rehabilitate these if they do not have a loose body. If they have a loose body, then I will scope them, remove the loose body, sometimes perform an MPFL repair at the site of injury. Then you got to decide if you want to do anything to the lesion. Most commonly, I neglect it because the natural history in a young patient of these lesions, medial patella, lateral femoral condyle, is actually very good. And if they have problems later on, it can be addressed. And they often have sort of an auto microfracture because they've taken off, their injury goes through the subchondral bone. So they actually do very well in terms of their condyle pathology, but if you want to treat them, maybe something simple to start. You could biopsy them for future use and or consideration for allograft if they fail. Then finally, probably the more complicated one is where they have fixed subluxation and tilt. They have lateral patellofemoral disease. Again, this is one, they've lived with this disease for years. And all of a sudden, maybe they heard that there's some opportunity to be treated and made whole again. But education and encouraging them to coexist with their disease is still my mainstay of treatment. We rehabilitate them, and we'll use injections. And if we're going to treat them surgically, we always will include some type of TTO, and then we might even do bipolar restoration. So this is a woman who has obligate patella instability when she extends. She got obviously a mechanical phenomenon where she has, really this is a J sign on steroids, right? So she comes up and she locks out. She's used to chronic lateral subluxation. We treated her cartilage problem. We did her MPFL, and even literally in her first post-op visit, just getting her realigned and unloading her probably helped her the most. I mean, she was 75% better in her first visit, forgetting about what we did to the cartilage, because obviously a little too soon to say what that's providing. She was probably 75% of her outcome was achieved in the first month just because we realigned her and got her patella stable. So we've become very interested. We have a series now on de novo. They look good across the patellofemoral joint. We have a large series that Jack and I have collaborated on for ACI. They look very good as well. And at least my initial entrance into patellofemoral osteochondral grafting was in failed procedures of the patellofemoral joint. Now, actually, we're quite comfortable, even given the topography of the patella and the trochlea, in doing an osteochondral allograft. And we had 2 of 14 failures in our group. Half were bipolar, half were unipolar, but all the others met in their patient-reported outcomes met MCIDs that were clinically important. So we think this is also a good option for the patellofemoral joint. So in summary, it's important to understand that chondrosis is often incidental, and we don't really have a firm understanding of the natural history of asymptomatic disease, so I let them go until they become symptomatic. I'll often observe them. Sometimes we'll provide injections for acute flares for those who can tolerate high-level activity. We don't take them out of play if they're tolerating it. We'll offer short-term solutions, debridement, especially in our high-level athletes, for those who can't tolerate their disease with activities. We'll offer long-term solutions if they fail their short-term solution, including osteochondral grafting. For every procedure you look at in the literature, look at the independent variables. The best prognosis is a younger patient, smaller defects who have been living with that problem for a shorter duration of time. And finally, if you guys are interested, just a little shameless marketing. This is a course that's in its 19th year that we run every year in Park City. If you're interested, that will be sort of case-based learning, not much in the way of didactics, but all case-based learning. That's from January 31 to February 3rd with plenty of time for skiing. So thank you very much for your attention. Okay, so now I got to moderate the same session, and I'll ask myself a question. So do we have any questions from the audience? Not a one. Okay. How are we doing on time? It's 1. What time is it next? Okay, so why don't we let you're next, obviously. Okay, so we're going to let Andreas start, and maybe after each session we'll have the opportunity for questions, so think of something that you have as a small room, take advantage of it, and then we'll move on from there. Thank you.
So I could say just like he said, because Brian, I think you gave 2 of my talks and Jack's talk.
That's what I was asked to do. I do what I was asked.
But that's how you learn best, by repetition. So the one thing you need to know about Brian is that he usually talks pretty fast, and he thinks 10 times faster than he talks. So he probably did your taxes right now as you were giving this talk. So I've been asked to talk about just the surface repair options. And there are a few. There's marrow stimulation, particulated autograft cartilage, and perforated cartilage allograft. And as Brian had alluded to before, really the explosive growth in cartilage repair options that we've seen is in this field of allograft, as I had mentioned before, that's because of this FDA loophole. So for years we've had marrow stimulation, we've had osteochondral autograft, allograft, and ACI. And now all of a sudden we have a bunch of new exciting options as well, but all in the allograft world. So in 2017, these are the options we have. So we have debridement, you heard about that. We have marrow stimulation, and then there's a new term called marrow stimulation plus. I'll talk about that. Osteochondral autograft, allograft, particulated allograft cartilage, the perforated, and then ACI. And I'll just talk about the ones in red. So what is microfracture plus? I'm not going to go over regular microfracture or marrow stimulation. You've heard about this plenty of times. But there's this new term, microfracture plus. So why did we move from microfracture to microfracture plus? Well, there are concerns over the tissue quality with regular microfracture. Microfracture is not bad, but it has its limitations, and what we know is that it does not produce hyaline cartilage. It produces fibrocartilage, maybe there's some hyaline-like cartilage, in the best of circumstances. And sometimes stem cells don't really know what you expect them to do, and they don't take the let's try and go towards cartilage route. They take the one, let's go towards bone. And as you can see on that CT arthrogram in the red circle, that's what we call an intralesional osteophyte. So there was marrow stimulation done, and then instead of growing cartilage tissue, it grew bone. That happens somewhere between 30 and 50% of the time. And then you can also have a soft tissue response, but a soft tissue response that's not what you want. And you can see that here. So this is a patient who on MRI scan had a marrow stimulation before. On MRI scan that looked pretty good. But even on arthroscopy, if you just look at it, it doesn't look so bad. It doesn't do anything. It's amazing how after 20 years of PowerPoint, video is still not reliable. Good. But when you probe this, you can see that this is certainly not what you would expect to happen after marrow stimulation. This is completely soft tissue that might look fine if you just look at it, but certainly not functional tissue. So that's a failed microfracture procedure because of a biologic failure, and it just produced loose soft tissue rather than anything approaching cartilage. So what you try to do, well, you try and juice up microfracture, if you will. So you try and convince the body to produce better cartilage, make sure that it goes into the right direction and produce hyaline-like or better fibrocartilage, definitely not produce bone. So what's currently available in this field is, as Brian had mentioned, micronized cartilage that's extracellular matrix, essentially. No living cells, it's a powder. That powder gets mixed with either PRP or BMAC to bring some biology, and then you do a marrow stimulation of your choosing, whether it's drilling or microfracture, and then you add this paste to the defect. There's some preclinical data from Lisa in horses. There's some building clinical data in humans. It looks pretty promising, but no one can give you larger studies that have 2 to 4 years follow-up. I think, Brian, you're doing a study right now. There's another option that's been around for years, and actually this is one of the mainstays of cartilage repair in Europe, where access to osteochondral allografts is very limited, and many countries have actually gone backwards and now don't allow ACI anymore because it's expensive. So what do? They like the collagen membranes, and they know that if you have a repair tissue after microfracture that's oftentimes very soft, there are concerns that that early marrow clot gets just pushed out of the defect. So you combine the two, you do a marrow stimulation, and then you cover it with a collagen membrane. That technique is called AMIC. That's theoretically available here because we have these collagen membranes. They're not FDA approved for cartilage repair, but you can use them in an off-label fashion. You just need to tell your patient about it. There are large cohort studies, but large studies coming out of Europe that show pretty decent results in the knee joint. So that's called AMIC. It's an open procedure to put your membrane in, while the previous one, the micronized cartilage, that can be done arthroscopically. I'd already mentioned this sort of an extension of a microfracture idea. So you want to get stem cells into the defect. Mesenchymal stem cells are not that common in bone marrow. You heard Lisa talk about how you need to concentrate them, and then you can actually get decent amounts. But if you just drill a few holes in the subchondral plate and you rely on local bone marrow to come out, for a normal-sized lesion, maybe a couple hundred stem cells if you're lucky, and that might be all you need. But as orthopedic surgeons, we oftentimes believe in this more is better. So And this technique is one where you can take bone marrow somewhere else, where you can take 100 cc's, 120 from the iliac crest. Then you can spin it down, you can concentrate the stem cells, clot it, and then you can bring concentrated stem cells into the defect. So number one benefit is you can bring much higher concentrations of stem cells into the defect. And benefit number two is you don't have to mess with the subchondral bone, because that's one of the issues with marrow stimulation and microfractures, that you have to do something to the bone. You have to drill holes, you have to poke holes, and that oftentimes can lead not only to these intralesional osteophytes that we saw on the CT previously, but it can also lead to cysts, persistent edema, and pain. So this is an extension that pretty elegantly gets around those two limitations. Now going to the allograft tissue, particularly juvenile allograft cartilage. It's hyaline cartilage. It's harvested from, unfortunately, very young donors. The reason why it's harvested from young donors is because chondrocyte density in younger age groups is much higher than in us, older farts. And each individual chondrocyte is also metabolically much more active. So not only do you have more chondrocytes, but you also have young chondrocytes that are more vital and want to produce cartilage. This cartilage gets more sliced into small slices. They're cubes about 1 millimeter on each side. And look at this not as an osteochondral allograft. That's what we've been using for 30 years to bring structured cartilage into the defect, and that cartilage stays the same as the day we implanted it. This is really more a cell delivery vehicle. In that sense, it's more akin to ACI or MACI. So the cubes just bring cartilage chondrocytes into the defect. Those chondrocytes then need to grow out of the cubes and produce cartilage repair tissue. So this is cell-based therapy, just like microfracture or ACI. The indications for this, sort of small to mid-sized defects, about 1 to 4 square centimeter in size. I most commonly use that as an adjuvant to osteochondral allograft. So let's say I have someone who has a larger lesion in the femoral condyle, I do an allograft for, and they have a small lesion in the trochlea, tibial plateau, or the patella. That's more difficult to treat with osteochondral allograft. I would use this for the secondary defects. Really, you can use it in any location. You can do it arthroscopically. I've done that for the tibial plateau. That's actually easier arthroscopically than open, but it does need intact subchondral bone. So again, you need a good foundation for these techniques, so good subchondral bone. Results, Brian has gone over these before, but there's mounting body of evidence that this works, and works fairly well for the small to mid-sized defects. The pros, you can use it for any size and shape. This is a soft implant. You can shape that to anything. It's off the shelf. You can schedule the surgery whenever it's convenient for you. And you don't have to compromise healthy bone like you do from the traditional marrow stimulation. But you do need to consider the bone. So it's not good for osteochondral defects. It's cell-based, so it still has the same slow maturation and rehab and delayed return to play as you see in microfracture and ACI, and data is still limited. So if a patient asked me a couple of years ago, what can I expect? I had to say, I don't know, because the data is not there. Now it seems to be sort of 80% good or excellent outcomes around 2 to 5 years. There is an extension of this using autograft tissue. That comes from a study that actually both Jack Farr and Brian Cole had participated in called CASE. This is something that was done years ago here. Unfortunately, it was abandoned because based on how randomized controlled trials are run in the US by the FDA, it's very hard to enroll patients. But this trial, essentially, you took a cartilage biopsy, in a sense, you chopped up the autograft cartilage, that got put on an artificial membrane and then re-implanted in the same surgical session. And the outcomes of the phase 2 trial actually were very good. There are a few centers in Europe who use this mixed with BMAC. I had mentioned that in my previous talk. That seems promising by combining stem cells with chondrocytes. There are few reported outcome studies you see on this slide. So stay tuned. I think that's an interesting technique, especially in countries where you don't have access to the technologies we have here. The latest entrant is perforated cartilage allograft. This is a variant of an osteochondral allograft. It's called osteochondral allograft because microscopically you have a little bit and this is really just micrometers of bone. But it is by the company taken off, let's say, a femoral condyle sharply. So it's the complete structured cartilage layer with, as mentioned, a tiny piece of bone, and then it gets perforated both to improve the surface area for chondrocytes to come out, similar to the particulated that you heard about, but also to provide more of an area to ingrow and integrate with the subchondral bone. Because the historic teaching had always been, once cartilage is delaminated, you can't fix that back to bone. It doesn't heal back. Now, in very young patients, for example, after patella dislocations, that still seems to work. You can take these pieces and fix them back. In older patients, I would have said does not work. I think with this perforated, there's a chance this might heal in combination with a marrow stimulation. The benefits of this are it's flexible. So using an osteochondral allograft, especially for the patellofemoral joint, where you have convexity, concavity, and a lot of variability between patients, donors, and recipients, it's really hard to match that surface contour well. That's why ACI is still the mainstay for the patellofemoral joint, because you can shape it anyway. This here, at least potential, offers the benefit of being flexible, so you can also reshape it to match any surface geometry. So it's different from osteochondral allograft, but it is closer to osteochondral allograft than the previous to particulated, which is really just a cell delivery vehicle. This brings in cells plus structure. What are the prime indications? I'm not sure. This has been around for just a couple of years. There are no outcome studies published, so I can't really tell you where the prime indication is based on data. I can tell you by gut feeling, probably in the patellofemoral joint, because here you have the challenges matching the surface, as mentioned, and at the same time you want something structurally hard so that people progress with rehab a little bit more quickly than with cell-based therapies. But it also demands an intact subchondral bone. As mentioned, no results yet. So in summary, the surface treatment options are still viable options for cartilage repair. It doesn't always have to be an osteochondral autograft or allograft. However, you do need intact bone. So none of these things work if you put it on a broken foundation. ACI overall has the longest track record. Tom Minus will tell you more about ACI in the next talk, but that's mainly for larger defects. The particulated allograft tissue seems to create a niche for itself in the smaller to maybe mid-sized defects up to about 4 square centimeters. Both ACI and particulated share the longer rehab, a little bit more complicated rehab of all cell-based therapy, and then the perforated cartilage tissue, give it maybe a year or two, have more data generated, then you can tell your patients more reliably what to expect, but I think this shows early promise. Thanks very much. And then while Tom comes up, any questions from the audience in the meantime? Yeah, or you can just. Yeah, up here. Brian, do you want to have a discussion while he uploads his talk? Do you want to ask me a question? This is not my son, by the way. This is not my son, by the way. Yeah,
Andreas, will you treat lesions with subchondral edema or change on MRI with any of the technologies you just discussed?
So if there are cysts, I would say no. If they're large cysts, I would go to an osteochondral treatment because that is a one-stop procedure. It treats both at the same time. If there's a small cyst, you can say, yes, do a surface treatment, and you just bone graft that small lesion. Edema is much more difficult. There were some studies that show worsened outcome after ACI if you have marrow edema, but there was a more recent study that said there's no correlation. So I can't tell you where the threshold is. It just makes me a little bit more nervous if I see the whole condyle lighting up. I think that's an osteochondral issue, not just a chondral issue.
Okay. And then finally, how do we decide if we should do marrow stimulation with these procedures or not? What do you currently do? If you have any of these surface allografts or particular grafts, do you do marrow stimulation? How do you make that decision?
So for the particulated autograft, I just do a debridement preparation as I do for ACI. So for that, I don't do marrow stimulation. For the perforated cartilage tissue, it needs marrow stimulation, not necessarily for the stem cells, but if you just put that down on regular subchondral plate, I don't think it will integrate. So you need to somehow stir up, if you will, a healing response. You need some bleeding. I don't think you need holes necessarily. You can just do an abrasion arthroplasty, but you need to do something to tell the bone that it needs to get some healing going.
Jack, are you doing the same thing? Are you abrading it, putting holes? What are you doing? Okay, no holes. Okay. Any questions before we go to Tom?
Yeah, I have a question.
Please. Yeah. So the question is about the technique of marrow stimulation. You know what? I'm going to give a video. I have a slot to give a video technique and a little bit of background, so why don't I cover it there? Other questions? Tom.
So I saw lots of these adjuvant microfracture techniques by both of you. In your practice, when you have a weekend warrior come in, 20 to 40 years old, neutrally aligned leg, defect, 2 to 4 centimeters squared, what do you do?
The first thing I ask is who referred you? Because if they were self-referred, most likely they're not getting an operation. If they're referred from an orthopedic surgeon, most likely they've been through the gamut of something, right? So no prior treatment. Well, the first is making sure that they have concordant symptoms. So they've, and just to hone in, have I picked this up, or they already know they have the problem? What scenario is it?
They already know they have a problem.
All right, so they typically come with an MRI and X-ray. They've been told they have a problem. They're seeking treatment. So first is just looking at severity of symptoms and the nature of their symptoms. If it's typical, and I've now begun to sort of separate them out between load-based and those who have mechanical effusions and things of that nature, because I know it gives me a sense of the least amount I can do to get them well, even if they're only short-term bridging treatments. So if they have sudden onset of acute mechanical symptoms, effusions, things like that, I might actually just discuss first maybe non-surgical treatment, injection and so forth, whatever, and then if that doesn't work and they're sufficiently symptomatic that they require additional treatment, I may just talk about a scope and a debridement, okay? If they have load symptoms and it's a dry joint and it wasn't necessarily an acute onset, then I say if you're a perfect candidate, in my mind, for, say, marrow stimulation, the stuff that Andreas just talked about you can have on the shelf, and I'm not sure where I'm fitting it in my algorithm, because you can't have an osteochondral allograft on the shelf, you can't have ACI or MACI on the shelf. So first-line treatment, I try to do something arthroscopic, minimally invasive, if you will. So the load-related pain, non-acute, no fragments, I'm thinking that debridement probably won't work, but maybe I'll be surprised when I get in there. And then I'm thinking treatment is needed. And then I'm thinking if it's 2 or less, and well, in my practice, they're going into a clinical study because we have 2 or 3 we're still enrolling. But if they're not going into a clinical study, they may just get marrow stimulation. And then if they're bigger than 1, I will add, and I do it under power, just to give you the quick answer, I do it with drilling. And I'll add biocartilage just because it might help. If the study that Lisa and I collaborated on at Cornell showed, at least by MRI and second look, we think we're doing better. We will know hopefully clinically within about a year as we enroll multi-center. But even then we may not be sure because it's level 4. So all that being said, I will add for the bigger lesions some type of adjuvant, which would be biocartilage in this case. But if it's big and undefined and really degenerative, I may not do marrow stimulation, and I just debride them, and if they're not, and then maybe biopsy, or maybe plan to come back for MACI or probably an allograft. So there's no simple answer to that question. No, it's not. So I hope you didn't expect a simple answer, but debridement's still the mainstay of my practice for first-line treatment because we've done well, especially for the higher-level person, giving them all the limitations that they may be back.
Okay. Andreas, same question. Short.
No short answer.
I think if you had asked him to sum up the Middle East crisis or the solution to that, he probably would have been more concise. But there's no study data really that helps you pick between all of these options. So a lot of this is what your experience is. What are you good at? And we don't talk enough about surgeon experience for any of this. All of the surgery is really dependent on technique. If you're good at osteochondral allografts, then your answer should be an osteochondral allograft. So that just as an aside. If the defect is 1 square centimeter, I wouldn't open up the knee. I would try to do a marrow stimulation essentially, because I think there's some morbidity to an arthrotomy. Maybe not much, but there is some. If the defect is more in the 4 square centimeter area, then I don't believe that marrow stimulation will help, especially not if it's an athlete who is maybe 35, 40 and older. So for that, it's either ACI or osteochondral allograft. And for me, if the patient is patient, they have time, they like autologous, I go with ACI, but rehab will be longer than for an osteochondral allograft. So to try and come up with a concise answer, if it's a small defect, previously non-treated, younger age, then marrow stimulation I think is fine. If it's a little bit more on the larger end, 2 to 4 square centimeter, patients maybe a touch older, either ACI or osteochondral allograft, and then you pick what you have more experience with and how quickly the patient needs to go back to life, work, and sports.
When you debride them.
So most of the patients come somewhat pre-treated. If they have mechanical symptoms, I think, yeah, if mechanical symptoms are really in the foreground, then I think doing a debridement is a good option.
Okay, that's great. So I think you can get a sense that all of us base our treatment partly on the algorithms and partly on our personal experience and what your comfort level is with. I think for me, if I'd have answered that question, I'd have said small defect, first time chondroplasty, larger defect, first time chondroplasty, biopsy, possibly second stage ACI. Marrow stimulation, not in my practice. All I treat is failed marrow stimulation, so I have a bias against it. And a small defect, high-level person, I'd put an osteochondral autograft. So for me, it's chondroplasty, autograft, ACI. Failed ACI is allograft. Osteonecrosis is allograft. So, you can see that all of us, and Brian's got a very unique situation in that he's got lots of clinical studies and a very large volume practice where he can be the one who's evaluating all these new technologies, which I think we need to know about. So, time will tell. Anyway, I'm going to talk about ACI, a little bit different perspective than Lars. Lars has given us really the history of ACI and where it fits and what it can do. I'm going to talk a little bit more just about technique. So these are my disclosures. So this is generation 1. We know this one well from Lars's talk. And the technique, of course, is to let's see. Go back. Need my glasses. I guess the videos, for some reason, are not going to work because I have it on a stick. Oh, they are. Okay. Can we go back to the first video? I guess he's got the controls. That right there, 22. So the biopsy is taken after you've done an evaluation. I measure my defects carefully. I probe the adjacent tissue to try to get a sense of what we talked about earlier. So this one's roughly 25 wide and about 15 to 20 proximal to distal. I've assessed clinically the tracking. I assess arthroscopically the tracking. I determine this is a trochlear defect that is suitable for an ACI. So I then move on to take the biopsy. The biopsy, my preference, can we click onto this one, please? So my preference is the superior intercondylar notch. My secondary sites are the proximal medial trochlear edge, proximal lateral trochlear edge, or the sulcus. And so I've come down to the sulcus terminalis laterally. This is lateral wall. And you really need to kind of push down hard to scrape the subchondral bone. You want all layers of cartilage down to bone so that you can see the subchondral bone. And then you know that you have an adequate biopsy. And that's about the size of it. It's about 15 millimeters long, 5 millimeters wide. That's about 10,000 cells. And that's how much you need to take for your biopsy. I leave it attached distally. Then you can just grab it, snap it out. And you can see there's almost some bone on the back side of that biopsy. But you do need all layers of cartilage. The inadequate biopsies that are taken and don't grow are usually because you don't have all the cell layers. And when you're finished, you can just put them through a range of motion to make sure that you didn't. Click onto this one, please. that you didn't cause a weight-bearing lesion. But once you've done these enough, you realize that when you just go to the sulcus terminalis, you can see there anterolaterally that this is the sulcus right here. You stay anterior to that and you're fine. So this is how much tissue you need. It's a small amount, and that's enough to culture and expand. So Lars's first paper was the basis of getting this approved in the United States, and his patient follow-up of his first 153 patients were reviewed by the FDA in Gothenburg, and what they indicated for ACI back then were indications included femoral condyle or trochlea or failed prior treatment. Ages 18 to 65 was chosen arbitrarily. Not indicated was generalized osteoarthritis, prior meniscectomy, pediatric population, or the elderly. So we've moved forward to look at this, and if you look at cartilage repair on Google right now, there are some 9.5 million hits on that, so it's become very popular in our culture. Correction of background factors, what Wayne talked about earlier today and I alluded to before, as did Lars. You really need to pick up carefully the cause of the cartilage defect. They don't just happen. Something has happened such that the knee is breaking down. Malalignment, status of the meniscus, the ligament stability of the joint. And our preference is to do a biologic reconstruction by doing all the background factors and the cartilage work at the same side, whether that same sitting, whether that is whatever technique of cartilage, the background factors are addressed. So since then, we have looked at patella, adolescence, multiple defects. We've looked at what insurance has restricted us with, ages, complex reconstructions, concomitant procedures, and we've looked carefully at prior marrostimulation and its effect on cartilage transplant, as well as bony deficiencies and kissing lesions, patella femur, tibia on femur. So the open intraoperative appearance when you first open up a knee generally looks pretty bad. But by the time you've done an adequate debridement, and you can see I've taken down the anterior horn of the medial meniscus here to get very posterior. You can see it's a very long posterior lesion. You can't get there until you take down the intermeniscal ligament, come underneath, and then repair that at the end. So this is what it looks like when it's radically debrided. It should be a healthy-looking knee with potholes. That's an adequate debridement. And then the suturing technique, which we no longer have to worry about because we have MACI, which you glue down to the bone. But we were trying to suture it in a way that restored the top side and then fill it up with cells. So this is what they would look like when you did a good suturing technique. And here you can see this is a same patient, medial femoral condyle, patella, and trochlea. And you can see the trochlea is concave, the patella is convex, and the medial femoral condyle is convex. And this is a well-performed graft. The patella we started looking at first because these were the patients that see us the most. And our concerns were, why did the early experience with patella not show us good results? Because presently, patella, as you could see with Dr. Cole and Andreas's talks, the patella and the trochlea reproducibly give good and excellent results in ACI. So what was missing when we started? What was missing probably was just really focusing on the background factors. When you focus on realigning the kneecap and getting the patella centered and having the tracking normally, we found that the results with cartilage transplantation were excellent. Here you can see a second look MR and a second look arthroscopy. And one of the things that we frequently faced with periosteal graft with cells was hypertrophy of the fibrous layer, and patients would have some crepitus and have some mechanical symptoms, and often we had to rescope them as we did here to take away the periosteal layer, and the patients would do well. The early results, as you can see, Dr. Peterson's results, only 2 out of 7 of his first patellar transplants were good or excellent. But when he included those and followed them up and did realignments, his results went to 80% roughly, 79% good or excellent. And they were durable, out to 10 to 15 years. We then looked at our ACI patella with realignment procedures, and we found that we realigned the ones that needed realigning. The ones that appeared to track centrally or more traumatic, we left them alone. And especially the cases where Fulkerson's osteotomy in isolation did not do well, the type 3 and 4 lesions, medial facet and panpatellar, we still had good and excellent results. And when we looked at those over time, and Arvind von Kudel did a very nice review and correlated it with MR, found that if there was a good MOCART score, fill, and integration, there was usually a good clinical outcome. So by MR, we were being able to follow up our patients, and if there was a predictably good-looking MOCART score on MR, we had a very good result on clinical outcomes as well. So the summary here is if you do an isolated osteotomy for a type 1 or type 2 defect, inferior polar lateral facet, the Fulkerson osteotomy will unload those and the patient will do well. But a type 3 or 4 lesion will do poorly, and this is where ACI adds a distinct advantage over realignment alone. We then Andreas went and looked at our series and collected them with Scott Galogales, Brian's, and Jack's, and did a really nice multi-center center review of the 4 different centers and looked at 110 patients and looked at the clinical outcomes and found that 86% of our patients would rate their knee as good or excellent, and 92% would do the surgery again in the patellofemoral joint. So again, center after center, all of us found that these patients were doing good. My clinical fellow, Taka Ogura, a research fellow, has just finished reviewing our bipolar lesions, patella on femur, and with 60 consecutive patients, found that at 5 years, 84% have been doing well, and 81% at 10 years. So even with bipolar lesions, you can still get excellent clinical results with ACI. We looked at all surfaces, and so I'll just go through those outcomes. Meniscal transplantation with an absent meniscal often leads to cartilage loss as well over time. But if you look at meniscal transplant with unipolar or bipolar results, you can see here's a second look, 2 years after allograft meniscus and bipolar cartilage cell transplant. In our longer-term follow-up, roughly 75% of patients were doing well at 5 and 10 years post-op with this meniscal transplant algorithm. Uncontained defects used to be considered only something that you would use an osteoarticular allograft for, but if you properly prepare the defect and use transosseous sutures or suture anchors, my preference is to use transosseous sutures because it's effective and it doesn't cost anything, is very effective. As you can see here, this gentleman who had 2 weight-bearing, large, uncontained defects. They were prepared, the margins were drilled, and here we have 20 centimeters worth of weight-bearing transplants, and some 10 years later, this is 1 year, and 10 years he's doing well. Periosteum, although it was an excellent autologous tissue to start with, had problems up to 65% in different studies with hypertrophy and the problem of overgrowth, and we even classified it as different types of overgrowth, whether it's overlapping, fibrillating, or layering. But with the advent of collagen membranes, became available in May of 2007 in the United States, and we quickly moved on to collagen membranes and found that this was a very good thing. Here's an example of one of those young patients who had had prior ACI trochlea, the entire trochlea, and most of the patella. And at the young age of 35, 5 years after she'd had it done, at the age of 30, she had further progression of disease. And at this time, we went forward and did that with collagen membrane. So you can see it looks quite different. And we found that it really helped a problem which was hypertrophy, essentially eliminating hypertrophy and improving the clinical results. And Andreas led the way on this one as well, following up and looking at studies including Jack Farr, Brian, and myself, and Andreas's patients. Adolescents, these are patients who were off-label by the FDA, but Lars always told me these patients do the best, and I agree with them. The kids were harder for us to get approved because they were off-label, but their cartilage grows like cutting off a salamander tail. I mean, it just grows so fast. And they do exceptionally well. And we published on this with no evidence of any progressive osteoarthritic change over 10 years, protecting these knees and having excellent results over the long run. And then how about this arbitrary age by insurance of you can't do it on people over the age of 45. You know, it's 15 to 45 or 15 to 55. Well, we also showed that that's incorrect. The results are no different if you take out workman's compensation patients as a group. Most of our workman's compensation patients also had prior microfracture, which we weren't aware at the time was such an important factor. But you can see our results if they were non-workman's compensation patients over the age of 45 to 60, and they didn't have a prior microfracture, the chance of them having a successful outcome was 96%. So they do really well. Our arthritics also did well. So these were patients not with bone-on-bone changes on X-ray, but with peripheral osteophytes, intralesional osteophytes, 50% joint space narrowing. We found that if you transplant these patients and address background factors, you could also improve them from, this is the SF36. These are the bodily and mental health aspects of the SF36. And the thing about the SF36, it's an age-adjusted score. So if you look at our young patients that were 36 years old, there are age norms in the SF36. Before the surgery, these patients were here, almost 2 standard deviations away from the norm. And after they were transplanted, for 36-year-olds, they returned back to normal. So it was pretty powerful to see the effect of using cartilage cell transplantation in arthritics. ACL reconstructions, as Lars pointed out, these patients also do very well. But what was interesting to me was in our group we looked at this, and one of our former military fellows, because he has such an active young group of ACL injured recruits, wanted to look at all of them. So he looked at, we had 26 ACLs plus ACIs, 13 were primary ACIs, and 13 were revisions. And we found that if you looked at the two groups, the revisions had much larger areas of damage, but there was no difference between the clinical outcomes of the two. So that even though the pain was worse with the revisions at onset and their instability was worse, the final clinical outcome for both groups was you couldn't tell the difference. So that this was a pretty powerful statement to me that the amount of cartilage damage, even in these large knees, can be managed well with ACI and ACL. This was a sense that Lars and I had a long time ago, and was that every time we would find one of these ACIs that failed, and when we would do failed marrow stimulation techniques, when you scrape down all that abnormal tissue, you see these large intralesional osteophytes, you see the stiff subchondral bone, and it was our hypothesis that these patients probably don't do as well, these chronically injured knees. And so we reviewed 325 consecutive joints and compared those that had previous marrow stimulation to those that did not. And Andreas once again led this along with, and one of our other fellows who worked with us, Ron Royce, who's here today. Ron and the other clinical fellows on this series, they actually got all the charts from the referring surgeons and actually categorized the difference between an abrasion, a drilling, or microfracture, and then looked at the virgin versus the non-virgin knees as far as microfracture versus untreated defect, and found that the failure rate was dramatically higher if they'd had a previous microfracture. So something happened that it was different. I remember talking with Brian Cole when we first published this, and he says, I don't get it. I don't see that in my practice. And so, but then we found several others found the same thing. So I think we had George Bentley's group demonstrate a 5 times increased failure rate after a microfracture, as well as Petska's group, a 6 times increased failure rate. So there are other large series out there that have also shown the same. So I think when you have a prior marrow stimulation technique and alteration of the subchondral bone, you need to think about what you're going to do next. Or if you're going to stay with ACI, you need to think about how to manage the subchondral bone or change techniques and go to an allograft. And then the contained osteochondral defect, as Lars showed, was an interesting animal. We see this frequently, avascular necrosis that's idiopathic, not the steroid-induced one, because then we see multiple defects. Bone cysts or failed osteochondral allografts, what do you do there, or what do you do with failed autografts and failed synthetic plugs? So you have these defects. And I used to just do autologous bone grafting in isolation like Lanny Johnson talked about in CPM, because I didn't know how you could apply cells. But I thought this was brilliant. This was, Lars figured this technique out, where you basically bone graft and then isolate the marrow-derived space with a membrane, and then put a second membrane on top and inject the cells in between as a sandwich. And this has been a real powerful workhorse, and I'll describe that later. We just looked at our results of my earlier series that were treated with autologous bone graft alone against the sandwich techniques, and there's a dramatic difference in the survivorship when you add cells, as you can see on this top line. Oops. On this, this is a survivorship, bone graft and cells. This is bone graft alone. So there's marked improvement in the clinical outcomes. Increasing the exposure really makes it much more accessible to move on to larger and more pronounced defects. And this proximalization of the tibial tubercle when you're doing a tubercle osteotomy has been a very useful trick for me. Here you can see by doing such a proximalization and taking down the menisci, you can really expose all the tibia and the femur and just do these very, very large defects. And this is something that I really couldn't have attempted without collagen membranes. You can't suture and find this much periosteum, but when you can just prepare all of it and then inject it with cells, you can do very large defects, like this young man who had a double osteotomy in that transplant because he wanted a biologic reconstruction, and here you can see him hiking. So finally, how about the bipolar tibiofemoral lesions? We're just getting these just ready now. I didn't realize we'd done so many, but we have a group of 56 patients with bipolar tibiofemoral lesions, and find that even there, we're looking at a very good survivorship of 80% at 5 years and 76% at 10 years are still functioning well. And there's a big difference, though, between the outcomes with periosteum versus collagen membranes. We found that with collagen membranes, our survivorship was 97% and down to 61% with periosteum. So it seems like the outcomes with the collagen membranes are much better. We just received a publication notice for this article. Our first small cohort of patients, definitely my learning curve, but despite 20-year minimum follow-up in 23 knees, 63% of the patients are still functioning. Some of them required revision, cartilage repair, so that roughly 80% of these patients maintain their native knee 20 years later, and the starting age was 36. So they're now in their mid-50s with their native knee. So thanks for the time and the opportunity to present our data and follow up.
Any questions from the audience? Tom, I have one. Who's not a candidate for ACI for primary treatment of a big symptomatic defect?
I think that's more the patient than the technique. So I think if somebody, probably would eliminate them from cartilage repair with other techniques too. They have to undergo the rehab, the absence of impact loading sports, BMI over 35 for us for sure. We won't do an ACI. I don't know if maybe you might do an allograft in that situation, a larger, heavier male.
That's what I'm trying to get at. Like in your thinking,
yeah.
What pushes you not to do ACI, but do
Right.
some other cartilage repair
Yeah,
technique?
so allograft for me is failed ACI, a very large male maybe. I might do an allograft as a first treatment who's a little bit older, maybe 40s or 50s, or a avascular necrosis for steroids. We have a big group of Dana-Farber cancer patients who come to us in their 20s, and they have steroid-induced AVN, multiple defects, big metaphyseal infarcts, and they all get allografts. That's very effective for them. I wouldn't consider sandwiching or anything else with ACI with those conditions. But a large lesion doesn't deter me from doing ACI. I find it very effective there. It's really more the condition and the size of the patient, the activity of the patient, and them agreeing to go along with the rehab.
Okay. Any questions? All right, so where are we at? It's 1:50. So we're here. So you want to do 50? You want so
we have a break right now.
yeah. So 2:05. We'll come in at 2:05. So we'll take a break till 2:05. So make sure you visit the vendors as they've obviously helped to support this meeting. Okay. Thank you. All right. All right. Good job.
So if we can start trickling in here, we're going to have another session, and this the importance of this was pointed out by Lars in his talk, that no matter what you're doing and trying to attempt with cartilage, if you don't treat all the comorbidities appropriately, you're not going to have a good result. So we're going to focus on the comorbidities, and Tom is going to talk to us about osteotomies about the knee. Tom?
So I'll talk about tibiofemoral osteotomies, and I think the patellofemoral group is going to follow right after me. So as you can tell, most of us really believe that alignment is crucial. A straight leg is a good leg. Long-distance runners who run into their 80s are usually people who do not have varus or valgus. So the forces across the joint are really critical to maintaining good outcomes. So why are osteotomies useful? Well, in isolation, it used to have a lot of myth around it, but it really is a simple procedure. It's a biologic solution. It preserves the integrity of the joint, and it's amenable to salvage or conversion to a total knee if it's done properly. There are no implant-related activity restrictions. The outcome data for isolated osteotomies are good. The outcome data for osteotomy with cartilage repair is better. So the principles are realignment of the limb. In the varus knee, the deformity is nearly always in the proximal tibia, in the metaphysis, and our goal then is to restore the alignment and bring it out, and so the correction is done usually through the tibia. So if the mechanical axis comes here, our goal in cartilage repair is to mechanical axis at 0. Coventry would bring it over here, 62% across the width of the leg if it was a bone-on-bone situation. I don't think that people today would do that because patients find it unacceptable when you get them that far over in a young person. So I overcorrect them by 2 degrees to the lateral tibial spine if they're bone-on-bone, and just to neutral if it's for cartilage repair. In the valgus knee, it's the opposite. The deformity is usually in the distal lateral femur, where usually there is hypoplasia of the lateral femoral condyle. That's not really illustrated in this diagram that well. But basically, the height of the lateral femoral condyle is proximal to that of the medial femoral condyle, and it's smaller in the AP and the ML direction, and so that there's a superior lateral slope to the joint line. And when you do a varus-producing femoral osteotomy, you make the horizontal joint line. Usually the talus is also oblique, and you bring the leg into neutral. The joint line's parallel at the floor, parallel at the ankle. And again, in cartilage repair, we just bring it to the midline, and in bone-on-bone, we bring it 2 degrees over into the medial tibial spine. So the anatomic situation that I look at when I correct these: varus knee, I check that it is in fact a tibial deformity and that it's not through the shaft of the femur, because some people do have varus femurs, but that's unusual. That's usually some disease like vitamin D deficient rickets or post-traumatic. The valgus knee, again, I look at the distal femur. That's usually where the correction is. I look at the leg length very carefully. There's nothing worse than making somebody shorter or longer than they should be. They're very unhappy about it. So if somebody has a valgus knee and a short leg, I'll probably use a opening wedge osteotomy. If they have a valgus knee and a long leg, I'll do a closing wedge. If it's a really severe deformity, 15 to 30 degrees, I'll use a supracondylar reverse dome osteotomy, which is a really powerful osteotomy. The pathological situation, are we looking at cartilage repair with a relatively well-preserved joint? Are we looking at osteoarthritis with bone-on-bone changes? And is there instability secondary to the sagittal slope of the tibia? PCL stability can be enhanced, or instability can be enhanced by increasing the sagittal slope, and ACL instability can be enhanced by decreasing the sagittal slope. So in planning tibial valgus osteotomy, closing wedge is rarely performed these days. I still do it occasionally when I need a source of bone for bone grafting and osteochondral defect, or if the leg is long, but otherwise my preference is an opening wedge. It's technically easier to do. You don't have to take down the muscle compartments. It will make the leg longer, so make sure you don't have a long leg to start with. The reverse dome osteotomy in the tibia as well is very powerful. Again, I use this for my about 10 to 20 degree correction or up to 25 degree correction. These are usually Blount's disease patients or occasionally rickets, or the other indication is Paget's disease. I've done those as well. I mentioned the amount of correction depending on the degree of damage to the joint surface and loss of joint space. The other thing I want to mention is trying to stay out of trouble. So tibial osteotomies can cause vessel injury, and I learned this myself directly. There was a case that led us to write this study with Karl Winalski. I had a closing wedge tibial osteotomy that I performed, and when I took the wedge out, I saw two ends of a vessel looking at me. Tourniquet was up, and they were small vessels, but I'd never seen them before, and I didn't know that they belonged on the subchondral bone cortex. So I went next door and talked with my chairman, who was operating in the next room over. He came in and had a look. He says, I don't know, I've never seen that before. And then he says, but go down the hall where the chief of vascular surgery is operating right now and ask him to come in. So I went down the hall, I brought him in, and he had a look. And he said, I don't know what it is either. He says, why don't you just clamp them off, let the tourniquet down, and get a vascular ultrasound, and we'll see. So I tied the vessels off, we did the ultrasound, and we found that the foot was good pedal pulse, and then we just went ahead and completed the osteotomy. But for me, it was traumatic, knowing that I didn't know what it was. And so a couple years later, I had a medical illustrator writing an article for me, and I saw these diagrams that I'm showing you right here. And I said, what's those diagrams about? He said, well, there's 3 malpractice cases in Boston right now where these vessels have been cut. And so I had to go do research on them. And so it turns out that this is the embryology of the tibialis posterior and anterior and profundus arteries of the femur. And you can have incomplete obliteration of the vessels, but you can have a patent tibialis or anterior artery that goes anterior to the popliteus and rests on the back of the cortex. So Carl and I went forward and looked at the first 800 where the incidence was 8% on MR, and then went up to 1,350 MRIs and found that the incidence was about 3.8%. So it exists, it's there, and these malpractice cases were because the tibialis anterior artery that was aberrant was the primary vessel to the leg at this level, and it resulted in 2 amputations and 1 compartment syndrome. So it's real. It's now published in American Journal of Sports Medicine, and it's something that I think people should be aware of. So preoperative planning, I look at leg length, joint obliquity. In my series for isolated bone-on-bone medial disease, my patients were 44. Back when Coventry did his, they were 65. So it's a different group of patients now that we treat that are more active and much younger. This is why HTO got a bad name. This is the way the old technique was done. Closing wedge, put them in a cast with the knee in extension. You have this big metaphyseal-diaphyseal mismatch. You have an oblique posterolateral incision, lateral incision or transverse incision, or oblique hockey stick incision, so it's hard to do the total knee following and watching out for the skin bridge. They all get patella infra as well. So today's modern day techniques, we try to keep the knees moving well. This is a closing wedge osteotomy with a 10-degree angular correction. I set up opening and closing wedge osteotomies the same way. They're done under general or spinal anesthesia under fluoro on a radiolucent table. I use the tourniquet, I use a thigh post and a foot post to allow 90 degrees of flexion. This patient had over 10 degrees of correction. If you do that through the proximal fibula, you'll get a very lax posterolateral corner of your knee, which the patient will not like, so you want to keep that side intact. So you need to do an osteotomy at the tibia and mid-shaft fibula, and you want to be at least 15 centimeters below the fibular head so that you do not damage the extensor hallucis longus branch, motor branch. On the anterolateral side, you take down the anterolateral muscle and below the tubercle. You then have to go around and release the anterior aspect of the tib-fib joint, and this is where I found out that the tib-fib joint is a very strong capsule, and it really stabilizes the lateral side of the tibia. So when you do your opening wedges, you want to aim to this joint because that's going to give you added stability and you won't displace your osteotomy. This is a calibrated jig. This was the old natural knee jig. It's now marketed by Zimmer. It still exists. It's a very nice calibrated jig system. And it goes anywhere from 6 degrees to 20 degrees, and it closes at a central radius so that you can just take out a nice precise wedge. And that's the wedge you take out, small, because it's lower down on the tibia below the tubercle. You have to watch you don't crack your opposite cortex. Once you get into the cortex down lower, it's easy to displace it. And then we've already packed the back of the knee with sponges to protect the vessels and the nerves, and then we just go ahead and close it, and then plate the fibula as well. So that's a closing wedge osteotomy with a correction of greater than 10 degrees. Under 10 degrees, you don't have to go mid-shaft fibula. You can just do it all through excision of the medial part of the fibular head. And that's what it looks like when you're done. Post-op, I use a pericapsular infiltration. I infiltrate all the periosteum and the soft tissue envelope with a mixture. You can use Exparol. I use a very inexpensive mix of ropivacaine, Toradol, clonidine, and epinephrine, mixed by the pharmacy in saline, and we infiltrate everything. You virtually have no pain in the patient post-operatively for 12 to 18 hours. I put drains under the anterolateral muscle compartment, TED stockings, get them up right away. Aspirin, baby aspirin twice a day for 3 weeks. CPM, then a stationary bike by 1 to 2 weeks. Touch weight bearing until we see bone is healing with a closing wedge. It's usually 6 to 8 weeks, and it's quite solid. That's the advantage of a closing wedge. And you don't want to overcorrect. This is what you want it to look like when you're done. You want it to be a straight leg. Now, how about opening wedge osteotomies? For me, this is my go-to operation now. Very predictable. You can dial it in accurately. You can increase the leg length if it's a short leg. And you don't get metaphyseal-diaphyseal mismatch. So if you do a total knee in the future, it's a nice-looking tibia. It's easy to do. And you can do biplanar correction here. You can correct the coronal geometry and the sagittal geometry. You can increase or decrease posterior slope, and you can get a good coronal correction. The disadvantage, it does need a bone graft. Well, the Europeans don't use bone grafts, and that's because they don't have allograft at their disposal. So they put their locking plates on and let the tourniquet down and allow it to heal. But having gone over to Europe on multiple occasions and followed patients with tibial osteotomies, they take a long time to heal. They take 6 to 9 months to get solid. I don't think our patients would be as happy with that. So I use allograft. I used to use autograft and realized that the allograft heals just as rapidly. Smokers, beware. This is not the osteotomy for smokers. I would use a closing wedge there. And of course, watch out for the lateral cortex, because if you break that lateral cortex above or below the tib-fib joint, if you break it above the tib-fib joint, you risk breaking into the lateral tibial plateau. If you break it below the tib-fib joint, you risk displacement of the entire osteotomy and loss of correction. So here's such a male. Varus knees, needs an 11-degree correction. He's got lax medial side, needs a 13 millimeter opening, and you calculate that on your digital x-ray. I've demonstrated here's the pes tendons right there coming across. I used to come up this high to take autologous bone graft to fill in. Now I go up to here because I use allograft. And so here's the longer exposure that is used for taking autologous distal femur. But the key here is to protect the back of the knee again, so I strip posteriorly. What I've done here is I've stripped the pes tendons distally and the superficial MCL periosteum proximally to the coronary ligament of the meniscus, just tacked it out of the way. So I can see everything. Here's patellar tendon. You can either go behind the infrapatellar bursa, or you can do an osteotomy and come behind the tubercle. You then cut across to the other side with a saw and an osteotome, leave the lateral cortex intact, gently open it up with a slight valgus force, look at the lateral side to make sure you don't break it open. And here, I'm concerned it's just really thin and possibly unstable, so when I see that, I usually put a staple on the other side just to make sure it doesn't pop open. It really offers a tremendous amount of rotational stability. It's more, rather than medial to lateral to medial, it's more anterior to posterior, so that you have good torsional stability, and then pack it with allograft bone. I use the Oates chisels, I pack them up, and I pack it nice and tight. And that's what it looks like. You then close your pes and your superficial MCL back. If the MCL is lax, you'll advance it. It gets nice and tight. And then you let your tourniquet down, and that entire allograft just fills up with bone marrow-derived cells, and it heals quite rapidly, about 8 weeks. So here you can see this patient was short. This was first-generation poodoo plate, but now she's equal in her leg lengths, and that's the correction we go for. I showed you before in my earlier talk about the tibial tubercle osteotomy is offering exposure. Once you get into big corrections, if you start doing a big tibial valgus osteotomy, you're going to get a patella infra. So what I do there is I flip the tubercle up like this, and then I put the tubercle back where it belongs at the end, and I fill the distal part of the opening with allogeneic bone, and that way you maintain the patellar height, and you can get a big correction so that it would look sort of like this diagrammatically. And if you have instability in the AP direction or PA direction, you can do an opening or closing wedge from the back to the front or the front to the back to increase or decrease your sagittal slope as well. Here's an example that shows both. This is a 54-year-old male construction worker, and everywhere he went, he was told he needed a total knee replacement because he already has a pagoda deformity, in other words, erosion of his medial compartment, and early subluxation, but not damage to his lateral compartment on a PA flexed view. So we talked about staging these knees because he owns his own company and he does a lot of the work. So in the off season, we did one side, and then a year later, we did the other side. And so this is what we did, and you can see with a valgus force and his tibia reduced laterally, the big deformity he has medially. But what we did is I stripped down the MCL, and then we opened it up with laminar spreaders and reduced his joint, packed it with allograft bone, advanced his MCL, and that's what it looks like. Just got his mechanical axis neutral, and that's one side, and you can see the deficiency here when we restored his patellar height, because otherwise it would have been way down there. And then we did the other side, and that's what he looks like 2 years, and now he's 12 years post-op and doing very, very well. So on the femur, the same algorithm holds. You can do a medial closing wedge, lateral opening wedge. That's based on leg length and the amount of opening I do. I don't open anything more than about 15 millimeters laterally because the entire lateral side of the knee just gets too tight. The IT band is tight. The whole lateral complex of the knee is tight. Reverse dome varus femoral osteotomy, again, very powerful osteotomy. And tibial varus osteotomy I mentioned mostly for completeness sake. Small corrections, 6 degrees or less, it works really well. But more than that, you start developing obliquity of the tibial joint line. So here's a closing wedge femoral osteotomy. This was done years ago with a 90-degree blade plate, which is the way I was trained to use. These are big, bulky plates. I don't use them anymore, and they're not necessary. So you take a closing wedge. I still just use the calibrated jig I showed you on the tibia. I use it on the femur, flip it upside down. And presently, instead of a 90-degree fixed angle blade plate, I just use a small tibial locking plate off the tibial synthes buttress. It works really well. It flips upside down. It fits perfectly. And it's just a very easy a plate to apply. Again, opening wedge femoral osteotomy. This is about, I think, a 15 millimeter opening. Again, that's probably about as much as I would want to do. I've found once you start opening them on more than that, the problem is on the lateral film, it's very easy to flex the distal fragment and break the medial cortex, and you have a completely unstable situation. So in that situation, I go to a reverse dome once they're more than about 15 to 30 degrees. Here's an example of a distal femoral reverse dome osteotomy. I have a video on it that will go through the technique carefully afterwards. But you can see here, this was about a 15-degree correction. I've done up to 30-degree corrections. But this, you basically cut the femur in this direction so that when you roll it, you really don't cause any deformity of the distal femur, as you can see here once it's finished. But you can get really large corrections, and you don't have to worry about all the lateral structures being lengthened. So the results, these are older results, but I think they still apply. I think the results that we've looked at are still much better. Roughly, good and excellent results at 5 years are much better. Across the board for tibia and femur, they're about 80%, and they drop down to about 60% at 10 years that are still good and excellent. And about a third of patients may need some type of further surgery at 10 years when it's bone on bone when we get them. Cartilage repair is a very different animal. These are very durable long term, and we're just starting to review ours now. So in summary, osteotomies around the knee, predictable good and excellent results in about 80% at 5 years, 60% at 10 year. You can maintain youthful quality of life activity level because there's no implant-related restrictions. Low complication rate if you just think about the structures that are around there and just go slow. And you can plan for future reconstructions by the osteotomy technique, not distorting the femoral or the tibial anatomy, and by the skin incisions you use. Thank you.
Tom, come here. Tom, when you're doing these with cartilage restoration, what are your considerations on doing these in a staged manner or concomitantly?
The thing about doing this staged or concomitantly, I think that's an individual consideration. If you're to stage it, you'll do your osteotomy first and come back and do your cartilage repair. The thing for me, though, is that I do a lot of them, so I do them quickly. I try to keep my tourniquet time for the entire procedure under 2 hours for the osteotomy plus the cartilage repair. And then the thing about it is when you do the osteotomy, the exposure's right there. And you're looking at it and you're going, geez, I hate to bring the patient back again because I could do the cartilage repair right now. So I think it depends. Again, this is a surgeon thing. If you're comfortable with doing this stuff and you do a lot of it, doing it all at once and getting rigid internal stabilization, you can move the knee immediately with cartilage repair. So I'm aggressive with doing them all at once and getting them moving. It's all about stiffness. As long as they don't get stiff, they're going to do well. If you don't do a lot of osteotomies and you feel more comfortable doing it in a staged fashion, absolutely get your osteotomy done first. You may find the patient does so well with the osteotomy alone that they may not want to have the cartilage repair the second stage. So that's something that is possible too.
Thank you. Any other questions? Yes, please. Lars.
I totally agree. When you do these opening wedge osteotomies or closing wedge, if I do a closing wedge osteotomy in the tibia, I always multiply perforate the medial cortex with a drill before I try, so I can osteoclase it and not fracture it and have it displace. And you go slow because you want to look at your fluoro when you do it, so that when you put your fixation on again, that's another time you can displace everything. Once you start putting those screws in, before you know it, the distal screws, you may get such good purchase, you pull it and you displace the osteotomy to the plate. So you have to really be careful when you're completing and closing the osteotomies and applying the fixation, that you don't break the opposite cortex and that you don't displace the osteotomy with the fixation. Those are two really important points.
Thank you.
Okay.
So next, Andreas is going to speak to us about meniscal deficiency and the treatments thereof.
So meniscus, there's been increasing talk about preserving meniscus. It used to be that you had a meniscus tear 40 years ago, that meniscus essentially was removed. Why? Because you just risk re-injury. Why bother? Let's take that little remnant that supposedly had no function out. Turns out, actually, meniscus has a lot of function. All of us realize that. The lateral meniscus transmits about 70% of the lateral joint stress. Medial meniscus, a little bit less, 50%. But especially as you come into more flexion, more and more of the transferred stress goes through the meniscus. So meniscus is an important part of the knee not to be sacrificed unless you really have to. So what happens after meniscal deficiency? So now you don't have the quote-unquote shock absorber anymore, and more of the load gets transferred directly from cartilage to cartilage. So you see increased loading. You have an about 30 to 70% risk of developing OA after removal of meniscus. And it doesn't quite linearly scale the risk of arthritis with how much meniscus has been removed. I'm sure somehow it does, but it is so hard to quantify exactly how much meniscus we remove that that's an almost impossible study to make. Plus, the development of OA can take years, and doing studies that span decades is a little challenging. But sobering fact, relative risk of developing arthritis is 14 times increased after a at least larger meniscectomy with matched controls. That's a huge increase in risk. And it doesn't have to take decades, depending on how much you take of the meniscus, which compartment you treat, and then also things like malalignment, weight, and just biology. That can go pretty quickly. And this is an example of a 28-year-old who on the left side, 6 months post-op, he lost some of his lateral meniscus, still looks pretty okay, and then 18 months later, so 18 months after meniscectomy, that is a horrible compartment. That went within a year and a half from perfection, if you will, just a meniscus tear, to what most people would say this is OA in a then 29-year-old. The picture on the left, that's a 27-year-old who had a pretty large meniscectomy, 7 years, so you can say, well, 7 years, that's great how long it lasted, but nonetheless, he was still only 24. So keep these pictures in mind every time you see a meniscus and really ask yourself, is this something that I can somehow repair? I'm not talking about the degenerative tears, but especially if you see a younger person who had a bucket handle, try everything you can to repair that bucket handle. If you see a young patient who has radial tears, the old mantra is you can't repair them, but we're doing more and more posterior root tears. In a sense, those are radial tears as well. Try everything you can, repair radial tears. If it fails, so be it. But if it works, then it's been all worthwhile. So these just pictures are usually better than words. This just shows you in a TEC scan how high the load goes if you have a meniscectomy. The more it turns from blue to yellow and red, that's higher pressure on the left side. This is essentially looking at the tibial plateau, if you will. With an intact meniscus, yes, you do have a force spike right in the center of the weight-bearing medial femoral condyle. If you have a meniscectomy, now all the force gets transmitted just through that cartilage-to-cartilage contact right in the center. There's nothing being transferred through the meniscus itself. And then if you do a medial meniscus bone graft, that stress comes back down, not quite back to normal, but Brian and Jack had showed this a long time ago. You can reduce it to almost normal levels. What are the contraindications? Get that off the table quickly for meniscus transplantation, where if you have established osteoarthritis, and there's really not a great threshold to say when do you still have cartilage defects and when do you already have osteoarthritis. As a rule of thumb, if you see it on x-ray, that's when you start thinking about osteoarthritis. Certainly if you have more than 50% joint space narrowing, that would be a rare patient where I would say, let's think about cartilage repair and meniscus transplants, maybe just an isolated osteotomy. Cartilage defects, ligamentous instability, malalignment, those are not contraindications, but it's also not something that you can ignore. You just need to take care of it, as you heard Tom tell you just a few minutes ago. The one thing that to me is a little bit of a challenge is condylar flattening or osteophyte formation. So these Fairbanks changes that you get pretty reliably once you lose your meniscus, that the femoral condyle, the periphery, either medial or lateral, goes from nice and round to more flat. That's a predictable response after losing meniscus. That also causes, or is thought to cause, extrusion, because now that meniscus can't tug in nicely anymore, because the meniscus is shaped like a triangle, it needs something that curves up to give it room. If you have flattening of the condyle, there's no room. So you can imagine how there would be a tendency for that to extrude. My problem is most patients, by the time they really see us, by the time they get symptomatic enough to say, let's do the surgery, have already developed some changes. So for me, that's a relative contraindication, just because I don't really have that many alternative treatment options. The indications now, that's more tricky. So number one seems obvious, meniscal deficiency. A little bit more to that. A symptomatic patient, that's also tricky because not everyone who has no meniscus has pain. Quite frequently, actually, when patients come to you, they have this completely beat up meniscus, they have lots of symptoms, you do a meniscectomy, and you worry that, oh my God, how is this gonna work because there's no meniscus left. They come back and they usually are pretty happy. Oftentimes they come back 6 weeks later and they say, I'm back to playing basketball. Of course, I'm not going to go through big surgery because I feel fine. How could I be better? And then there's a subset with patients who have instability, multiply failed ACL reconstructions because they don't have the meniscus as a secondary stabilizer. So those three you can consider. The one difficult question, that's the tricky issue, is how much meniscus has to miss, has to be gone before a meniscus transplant, which is not perfect, it's good, but it's not perfect, but how much has to miss before I can make you enough better that it's worthwhile? Because it's surgery, it's a long recovery. You want to make sure that you give these patients enough of an incremental benefit that you and they say, I'm great, I'm happy we did this. So by and large, right now we say if you have less than a 5 millimeter continuous rim, that's where meniscal deficiency starts. If you have 99% intact meniscus, but you have a radial tear that goes through to the periphery, then you do not have a 5 millimeter continuous rim, even though most of the meniscus is intact. That's a meniscal deficient knee. We see that with posterior radial tears or these lateral meniscus tears that are right in the popliteus hiatus. And Brian had done a study looking at the effects, and a complete radial tear is essentially as bad as a complete meniscectomy. Symptomatic patients, so when do you transplant after meniscectomy? So do you do it right away? And we all see patients that come back, or I get patients referred with a note saying, sorry, I couldn't repair it, I feel bad for this patient, I think this patient will develop arthritis, would you consider a meniscal transplant? And the patient comes in and that's the one playing basketball saying, no, I'm not having surgery, I feel great. So how do you deal with that situation is difficult. So generally, unless someone has symptoms, it's hard to justify doing surgery because something can always happen. There are risk of complications. Meniscal transplants, we usually say they last you about 10 to 15 years. They don't completely integrate. They don't completely get revascularized. So there's a little bit of a ticking clock from the time when I put this in. So generally, if patients come, I want them to want the surgery. So a symptomatic patient is one main thing. They need to have, obviously, same side pain. If they lack the medial meniscus, you want them to have medial pain, not lateral IT band syndrome. Swelling is a pretty good indication. So if I have a patient who, because of my actions, is meniscal deficient, I couldn't repair you, I say, if you have some achiness that goes away pretty quickly, that's one thing. But if your knee starts swelling, you got to come back and let me know, because that is a symptom. And then what about the young asymptomatic patient? I told you the relative risk is 14 times, so we know how this is going to end. There's pretty much no good outcome if you wait long enough after subtotal meniscectomy. So that makes this discussion so complicated. We know bad things will happen, but if we have an asymptomatic patient, it's still difficult to say, let's do this surgery. So you want to really keep a close eye on them. Either you do serial MRI scans if you want to do that, or you just counsel them, and they need to be honest to themselves, their parents, to you, that if they have symptoms, they need to come back and we need to talk surgery. The subset of instability, failed ACL. The meniscus is a really important secondary stabilizer. Historically, we've said the medial meniscus, but turns out the lateral meniscus plays a role as well. Makes sense. Lateral meniscus, that's where we usually see meniscal tears in the posterior horn with an acute ACL tear. But if you don't have a meniscus, it leads to increased tibial translation. That puts more stress on your ACL reconstruction and can lead to an increased failure rate. If it's an asymptomatic patient in terms of pain, it's a primary ACL reconstruction and they don't have a medial meniscus. For me, that's not an automatic medial meniscus transplant, but certainly if somebody comes back and they already have failed 1 or 2 ACLs, then you should talk about this and very strongly consider a meniscus transplant. What's the role of the osteotomy? You heard a lot about osteotomy, but how does that play with meniscal transplants? I think the lateral knee is very meniscus dependent. If next time you look at an MRI scan, look at a sagittal image through the lateral compartment, the femoral condyle is convex, makes sense, but the tibial plateau, the cartilage of the tibial plateau is actually convex as well, so you have this round on round. That's point loading, that's not very good. If you think about what the meniscus does laterally, it really hugs those two convexities and vastly increases the size of the load-bearing area. So if you take that meniscus out, you lose almost 90% of the load transmission surface, and that's not good. There's a limit to how much you can correct with an osteotomy. So for the lateral side in a young patient, yes, I would do an osteotomy, but yes, I also would add a meniscus transplant. On the medial side is a little different because the tibial side on the medial tibial plateau is actually a little bit concave. So now you have something round sitting in something dished. There's a much wider area of load transmission even if you only look at the cartilage. So the medial side can tolerate meniscal deficiency better than the lateral side. So on the medial side, if you do an osteotomy and take care of the alignment, most of the time that's enough. You can add a meniscus transplant in very young patients if you feel you need to, but most of the time you don't have to. So what are the easy decisions for meniscus transplantation? If someone is somewhere between 15 and 50, so physiologically young, active, if they have a total meniscectomy, that's easy, that's black and white. If they have ipsilateral, weight-bearing pain, and or swelling, intact cartilage, or a multiply failed ACL with medial meniscal deficiency, those are candidates for meniscal transplantation. The not so easy ones are well, you had a meniscectomy, you still have some meniscus left, it's not enough, you have some cartilage damage, so clearly you're not having enough meniscus to protect your cartilage, otherwise you wouldn't have a cartilage defect, but is what you have really that much worse than what a meniscus transplant can do for you? That's tricky and there's no easy line to draw. If you have cartilage defect at the same time, many insurance companies still say if you have cartilage defects with meniscal deficiency, then they don't allow either. Because for cartilage repair, you need an intact meniscus, and for meniscus transplant, you need intact cartilage. Ergo, they don't treat you, take an aspirin, go away. Luckily, we've done a lot of work with insurance companies, and they've come to see the light. So many Blue Cross plans in Massachusetts, for example, now allow concurrent cartilage repair. Asymptomatic patient, I think I beat that horse pretty dead. So are they really asymptomatic? Sometimes they say, oh, I don't hurt. What do you do? Well, I just read a lot. So sometimes you need to tell them, try age-appropriate activity levels and see if you're still asymptomatic. So sometimes you've got to encourage them to make themselves asymptomatic, and then you can do your surgery if you feel it's the right thing for that patient. And then for the high-level athletes, you heard Brian Cole talk about return to play. That's pretty high, and the re-rupture rate or tear rate is less than 20%. So it's reasonable. They just need to know that we give you a new lease. Maybe we added some miles to your knee. Use that wisely if that's important to you. So for lateral deficiency, coming up with some form of treatment algorithm. If they're symptomatic, transplant them, and if they're analogous, also add a DFO to that. If they're asymptomatic, do really close follow-up, especially in young women who are in a little bit of valgus. They can progress very quickly. For the medial side, it's a little bit more forgiving. If they are symptomatic and they're in neutral alignment, that's a transplant. If they're symptomatic and they're in varus, for me that's an isolated HTO. You can add a transplant if they're really young, but then they become meniscal dependent. So going back to pivoting sports might not be ideal. If they're symptomatic and have instability, then you do a medial meniscus transplant and a revision ACL. And lastly, if they're asymptomatic, I still tell them, certainly come back if you're symptomatic, but I'm not quite as paranoid as with the lateral compartment. Pre-op planning, there's been a lot of work done between X-rays, CT, MRI, height-weight ratios. Nothing has really been shown to be consistently better than just regular X-rays with this Pollard method. But you need to be roughly within 10% of the real meniscus to get low transmission. If you're much bigger than 10%, the meniscus is too loose. It doesn't really build up any hoop stresses. And if you're too small, then you have too many hoop stresses and you'll probably pop your meniscus and fail pretty early on. Return to activity, as mentioned, I don't certainly encourage them to go back to at-risk sports, so that's anything cutting or pivoting. So I tell patients, think about all the sports where you tear a meniscus. How did you tear your meniscus? And then do you really want to go back to that and risk another surgery like this because it wasn't much fun? So ideally refrain from high impact and cutting sports. If they have to return, wait at least 6 months so that at least they can get their muscle strength up and don't come back and maybe tear their ACL. In terms of the outcomes, Brian talked a lot about this, but generally I tell patients about 75% at 10 years. Short term, obviously it's higher, and more than 90% of patients generally are happy with them. Concomitant surgery, 90% would repeat surgery in this study between Al Getgood and Bill Bugby using osteochondral allografts and meniscal transplants. So very successful, meaning just because you have a cartilage defect, meniscal transplantation is not contraindicated. So in summary, for the symptomatic meniscal deficient patient, meniscus transplantation, I think, is a standard treatment that most insurance companies now cover. The prophylactic transplantation in someone who's asymptomatic but has meniscal deficiency is, that's a tough spot. That's a whole gray zone, careful discussion. It's not something where with knee-jerk always transplant for sure. As always, look at your comorbidities. Ligament is important, alignment is very important. And about 75% of grafts are functioning at 10 years. So certainly for young patients, this is a very attractive option. One sobering fact, even though for symptomatic pain relief, it's very good, it seems to only slow down, not bring progression of disease back to normal. I think part of that is because we cannot perfectly match the meniscus. We can't really perfectly build up those hoop stresses again. So it's better than not having a meniscus, but it's not perfect, and patients need to know about that. Thank you very much.
Are there any questions? Yes, Joe.
Andres, you alluded to this on several slides, but while you never want to talk a patient into surgery, the reality is, what is your relative threshold about encouraging the 18 or 15 to 20-year-old female who has had a complete lateral meniscectomy to go ahead with a lateral meniscal transplant? Because the natural history of that particular problem is they're
terrible.
going to get into trouble.
So the sad reality is that things can go wrong, meaning you can have complications and you can just have pain. The sad reality part of that is that we live in the US and patients can complain to the medical board, they can sue you, so all the unfortunate aspects of healthcare. The reason I mention that is I want patients to realize that they have a problem and to want a solution to their problem. However you get them to that is up to you, but you need buy-in from your patient. So if I have the 16-year-old who is going to be the next basketball star. And they come in with their family, and the only reason they come in is because some other surgeon has told them they have to come see you. But they feel fine. They don't want to disrupt their sport. The parents think that they're going to be the next Kobe. They don't really want the surgery. I'd be really careful talking them into surgery, because then if they have pain, it's your fault. On the other hand, I would encourage them to be active. I would encourage them to come back if they have symptoms. I'm pretty liberal actually getting MRI scans. If I can show them, hey, look, on the MRI scan, your knee joint is actually breaking down. You have effusion, you have edema, your cartilage is a little bit thinner, you develop a little defect. I just want them to realize they have a problem. Because as soon as they realize they have a problem, people are not stupid. At some point they realize they need a transplant. And for some people, they are on board. They come in, yes, I get it, doc, I want this. And other people, it takes 6 months or a year or maybe never. But you need buy-in.
So a similar take on this. This is two different patients. They're both in their senior year, soccer in the fall. They both have, one has a medial meniscus tear, one has a lateral meniscus tear. Now they're meniscal deficient. They both have scholarships for soccer next year. What are your suggestions to the athlete and the family? Because we see Brian can get his athletes back. Where are you on that?
So one question is, could you go to college without the scholarship? If they say, yeah, it's not life or death, I still get a good education, then I would more encourage them, if they're symptomatic, have a meniscus transplant. Your soccer career might not take off, but that's secondary. I've had a few kids, their only chance of getting into college was that scholarship, and then we say, it's not the best for your knee, but long-term your education is probably the most important thing. Do your scholarship and we'll manage your symptoms, and not do a meniscus transplant. Now, if they're malaligned, I think with an osteotomy you can actually go back to these sports. So I've had some of these kids, I would do an HTO or a DFO, because as soon as that's healed, I feel comfortable letting them do anything they want to do. With the meniscus, not so much.
Great. Thank you very much. Any other questions? Now, I was assigned the dry topic of patellofemoral biomechanics. I'll try to sprinkle some clinical relevance in here. My financial disclosures, I work with everyone. So when I'm looking at these and thinking about the biomechanics, we have to kind of back up and say, why did they get the lesion and what are they associated? You've already heard the importance of comorbidities, so that's what all this biomechanics, what we're trying to do is make an optimal environment. So many of these post-patellar instability patients, that's a distal medial patellar lesion. You've heard a lateral trochlear lesion. Actually, if you look in, it may be the very distal aspect of the trochlea, but many times the lesion will go all the way down onto the lateral femoral condyle, so always look in that region. Post-traumatic, many times these with a slip and a fall, these will be superior pull, and as you'll see, that certainly with any type of elevation of the tuberosity, that is actually going to increase superior pull type of forces. Osteochondritis dissecans may be completely independent of underlying biomechanical factors. And the unfortunate patient that we're seeing them for a cartilage lesion, and their really problem underlying this is a genetic predisposition to osteoarthritis. So we're really caught in a rock and a hard place with that poor patient. So our whole goal here is to optimize the environment for the biology of your restoration. So we're always thinking, what can I do to make our outcomes better? So in the unstable knee, we want to stabilize it. And then in the knee that has subluxation, chronic subluxation, we like to restore the contact area and further optimize patellofemoral forces. Force over area equals stress. So that's the whole idea. And you've seen, I don't use the word normalize because sometimes we're going to do things that are a little abnormal or we're not going to get them fully back to normal. We're just going to try to optimize that individual patients. So this is what we have in our toolbox. Basically on the medial side, we can look at the medial patellar ligament complex. You notice that I'm using the word complex, not MPFL. We can move the tuberosity a variety of ways. We can unload the lateral retinaculum, and finally we can change the contour of the trochlea. So the medial patellofemoral complex, It's usually the common denominator in an instability patient, so you have to be aware that they may have trochlear dysplasia, patellar alta, valgus malalignment, altered position of the tuberosity. So don't just focus on one thing. You have to make a laundry list and then see what's the maximal bang you can get for the minimal amount of surgery. So this is Miho Tanaka's work, and you can see the top red line that goes up into the quadriceps. So it's not just medial patellofemoral, it's medial quadricep tendon as well. And then this is Chalo's dissection. Two things I'd like to point out, that there are a couple extra important patellar ligaments. One is the medial meniscal patellar ligament, the other is the medial patellar tibial ligament. But if you look up at his MPFL, you can see he has much narrower dissection. So when you're looking at these anatomy reports, look and see how they did their dissections, because I think we can appreciate from the work of Tanaka, it's a much more expansive area on the patellar and quadricep tendon attachment. So if you section the MPFL, you can see the restraint to lateral displacement is markedly down. In fact, the next tissue that is holding you, besides the medial structures, is actually the lateral retinaculum. So if you do a lateral release in the face of medial disruption, you're actually going to have an increased risk of further lateral dislocations and may even add medial patellar instability. So I would certainly counsel against lateral release in the face of a dislocator. If we look at these two more distal ligaments, the meniscal ligament and the tibial ligament, some people have proposed these as an isolated treatment. Andreas's fellow looked at this and sectioned the MPTL and found that it does not participate in near extension activities. So your normal activities who have relatively normal anatomy, most of the time the patella is going out of place at around 20, maybe 30 degrees of flexion as they're falling and internally rotating. Those patients do not need to have that reconstructed. The one where this will probably come into play is those patients who have a dysplastic or hypoplastic lateral femoral condyle, and those patients are having dislocations in flexion. That's relatively rare. I see maybe a couple a year, and I have a fairly high patellofemoral volume practice. So most of the time you can focus on this proximal complex. Once again, the MPFL, it's a check rein, so it does not pull the patella in the groove. I do these a lot of times on teenagers, and so they don't have any understanding of the biomechanics, but I explain to them that their patella is their dog. We'd like to keep the dog in the yard, so we're going to put a leash on the dog, but we don't want to choke the dog. So you're not going to pull the patella back into place. You do that with altering the force vectors using tuberosity surgery. So don't use the term tension the graft. You want the graft out to proper length, and then it's fixed when it's out to the longest length, which is typically for the patella around 30 degrees. This just shows there's been a sort of a rush to use Shotley's point. It's not a point, it's a cadaver study of normal people. So they had normal patellofemoral anatomy, number one, and number two, it's a cloud. So this is the central aspect of the cloud of only 9 patients. You can see Stevens and Andrew Amos's lab came up with their own cloud. It's a little bit different. And Fujino has another cloud, and his is related to the anatomy off of the adductor tubercle. So I would encourage everyone to look and check both radiographic anatomy and then length changes when you're doing MPFL surgery. The MPFL, when it's reconstructed, even small errors in this graft length, there's been a couple studies that looked at Shotley's point and found that about 30% or 1/3 of the time it's right on, so it's got great isometric or anatomometric length changes with the MPFL graft. 1/3 it's off by 3 millimeters, and 1/3 it can be off more than 5 millimeters. So Andy Kosgaria showed that when it's over 5 millimeters, you can certainly get abnormal forces and cause deleterious either pain and or chondrosis progression at the patella or medial aspect of the trochlea. This just shows, once again, the sensitivity. The green line is closer to the anatomic center, and you can see it should become lax as the knee goes into flexion. So if you're both off, you can see 1 centimeter proximal, distal, posterior. So if you're off a small amount, and then you actually fix it at a different, you can have all sorts of bizarre forces and movements of the patella. So it's extremely important to focus on the proper position and also the proper position when you set it out to length. Now we'll move on distally to the tuberosity. So you can do a straight medialization, an anterior medialization, or just an anteriorization, and then you can either move it proximally or distally. So this is the tibial tuberosity osteotomy. You can see there's a variety there. You can see at the top, you can have an anterior medialization, an Elmsley, or a McKay. I'll show you an alternative to that. In addition, when you're focusing on osteotomy, everybody should be placed in a prone position because it's too much to get into, but a lot of these patients are going to have abnormal tibial torsion or abnormal femoral anteversion, so certainly put them in a prone position, measure that. Where is it supposed to be? We published a study, ours was around 10, de Jour's was 13, Pandit was around 10, so somewhere 10 to 13, and our measurements are off here and there, so I think the accuracy is probably 10 plus or minus 2. CT was felt to be equivalent to MRI by Shutley. It's probably not. Diane Dom and Levy looked at that and showed that the MRI actually underestimates for those under 20 millimeters, it underestimates about 2. If it's over 20, it underestimates about 4, which may be clinically relevant if you're having somebody that has a 22 per CT, but you got an MRI that's at 18. Number one, you need to rethink it. And number two, I think 10 years ago when I'd give talks on TTTG, nobody knew what TTTG was. Now everybody knows what it is, and a lot of people will say, well, I'm not going to do a tuberosity surgery at 19, but at 20 I'm going to. It's not that easy. There's too many other variables. So it's just one part of the puzzle. In fact, if there's marked trochlear dysplasia, just by definition, there is no TG. There's no trochlear groove. It's either flat or concave. Now, some people will actually measure it. They'll just cheat, go to the Roman arch, and take the center of that, and that's their TG. Well, that's not really the TG. So in that particular patient, I'd urge you to look at the work of Gerd Seitlinger, the TT-PCL. Under 24 is probably within normal limits for most patients. We also did a paper that correlated well with his findings. So I use both of these concomitantly, and there's ways that you can look at it to see, oh, both of them agree, I think it probably is elevated. Well, if the TTTG is elevated and the TT-PCL is not, that means there's probably something proximally. Maybe they have femoral anteversion. There's also a considerable amount of tibial femoral rotation, and that can change the TG, and yet the TT-PCL can be normal. So just one more tidbit of information to add when you're deciding on whether or not and how much to do a transfer. How we decide how much to anteriorize, these are Fujifilm studies. It looks like between 10 and 15 millimeters, you have optimal unloading of about 25%, not the 50% that was mathematically calculated by McKay, but around 25%. And if you get much more than 15, you're going to get more rotations. You're really going to rotate and put more loads on the proximal patella. In addition, you may get into skin problems, and under 10, you're probably not getting enough of elevation to warrant the surgery for what you're trying to do, unload the patellofemoral compartment. And Ryosuke Kuroda showed that certainly you don't want to over-medialize. If you do, you're going to increase not only medial patellofemoral forces, but also medial tibial femoral forces. This is just an example of a steep osteotomy. One of John Fulkerson's fellows measured this on CT and found that without violating the posterior cortex and coming immediately adjacent to the opposite side of the patellar tendon, he could get 60 degrees. So that's where the 60 degrees has come out in the literature. So that's sort of the workhorse because you can get about 9 millimeters of medialization with 15 millimeters of anteriorization. This is work by Cohen and Tessian showing they were taking patients that were scheduled for AMZ, and then they did finite element analysis and actually moved it over. And you can see they did steep, slope, straight medialization. The bottom line for this paper for me is that although there was a mean correlation of about 20% mean peak force loads at foot strike with this simulation, it was not the same for all these patients. So some patients had no effect whatsoever, and some patients had maybe 30%. Unfortunately, this paper was done before they were measuring TTTGs or TT-PCL. So it may have been what we're seeing is patients who really did need an AMZ benefited, and those that didn't need it, it didn't cause any benefit. So I think I actually called him and urged him to repeat it, and Cohen was in a testing's lab, and they left, and took the software with them. So I don't think it's going to be repeated anytime soon. So when planning these, you're thinking 60 degrees, and so that would be the workhorse. However, Beth Schubenstein and Sabrina Strickland have come out with a laboratory-based, and they looked at both patients and then went to the laboratory and duplicated it, and they could not duplicate 60-degree slopes, and theirs are more in the order of 45 to 50 degrees. There's several reasons for this. There's going to be a paper that I wrote a review for that's going to be in arthroscopy in the coming months, so I'd urge you to take a look at that. I think we may be underestimating it. That's the biggest bottom line out of that. As far as for patella alta and infra, why are those important? Because as we said at the very beginning, force per unit area, and alta, the forces are similar, but the unit area is markedly down. In fact, it's just barely, many times with high alta, maybe a ketone ratio of 1.5 or greater, the patella is not even engaged until maybe 20 or 30 degrees of flexion. And so it's seeing significant forces on very small areas. And those patients can have pain in addition to their instability, or chronically they can have a higher incidence of chondral wear. So what we would like to do is normalize. So I just didn't use the term, we're going to distalize. I want to emphasize normalize, because I don't want to take them past normal. I don't want to create patella infra. So most people are going to be, when you are going to start thinking about distalization, you want to have a reason to do it. So it's not, even though ketone ratios are between 0.8 and 1.2, we're not going to correct a 1.2 or a 1.3. Most doctors that are working in this area wait till a 1.4 or greater before they will distalize, because there are a significant number of complications that could occur with this. I'm using a V-type cut. It's different than my straight medialization or even anti-medialization. I just want to have a lot of cancellous bone to speed the recovery. Then we just measure the amount of bone to be resected, allowing for the amount of blade kerf, and then just distalize it and fix it. Philippe Neret published in 2012. He actually takes a little suture anchor and does a tenodesis back to where the original attachment site was, because he's worried about a, quote, windshield wiper sign. I have not been doing that, and a lot of people don't, and I haven't seen any, certainly no direct comparisons in the literature, and I haven't seen any deleterious effects of not doing it. This is just an example. Ketone ratio 1.4, and now it's down to 1 with distalization. These many times will take a long time to heal that distal area. Some people are bone grafting in that area. Certainly you want to watch the loads to this, because you don't want the fragment to break or even the tibia to break. This is a technique that Tom taught me, and this was published by Caton et al. And basically you can skeletonize the proximal aspect of the patellar tendon attachment to the tuberosity. You can skeletonize for maybe 1 to 1.5 centimeters, and then cut that bone off and then reduce it. Why don't you just push it up closer to the joint line? Because whoever that patient eventually sees for their total joint, if they have their tuberosity in the joint, it's not going to be very happy with it. It's going to make exposure very difficult. So this is just an example. This is an old traumatic lesion that resulted in, marked fracture deformity as well as the infra, and we were able to proximalize and get her fairly close to normal, at least within what we're shooting for. Straight anterization, this is possible. Brian alluded to it earlier. He had, did the study that showed us decreased by 25%. This is just a straight anterior to posterior cut. You don't want to have a first-year resident doing it, because you don't want to cut through the posterior wall. Then you're taking your coronal plane cut using a 90-degree saw, and then you can actually have a fairly flat plane with a wide area of cancellous bone to allow for good early healing. Trochlear dysplasia, that was my assignment. The various classifications are trochlear dysplasia. The most famous one is by Henri Dujour, that David Dujour is now talking about. So basically it's a very shallow groove, a flat or no groove, and then convexities, either convexity alone or convexity with a cliff, creating what he calls type D. Now that we're looking at these with 3D reconstructions on both CT scan and MRI, we're seeing that there's a huge subset. So you could have let's say you can have somebody who is flat. If you want to divide entrance, mid, and just at the level of the roof of the notch, what that morphology is, you can have flat, 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 or dome, dome, flat, or shallow, flat. So there's going to be, hopefully, we were just at the IPG, the International Patellofemoral Study Group meeting a few weeks ago, and we've been encouraged them to pursue this and actually change the classification system that I like is just, is it shallow, is it convex, or is it flat? And I think that's much more, it's easier transmitted from one person to another than saying, I have a type C or a type D. And then how much is the bump? A lot of people are arguing, when does that become significant? If the trochlear boss is greater than 4 to 5 millimeters, it's probably significant and is one part of the pathology. So the indications for trochleoplasty would be recurrent patellar instability with high-grade dysplasia. That would be when you would consider it primary at the time of MPFL surgery, and then secondary in the patients that have failed isolated MPFL reconstruction and have significant trochlear dysplasia. They need to have closed growth plates, very careful patient selection, and even de jure says this, they need to have intact articular cartilage. Well, this is a cartilage restoration talk, and so what I'd like to counsel, this can be performed if it's the patella that you're resurfacing. So the patella is dislocated, it has that distal medial lesion that maybe crossed the median ridge and is one of those that become symptomatic. So that's the one you might consider this in the face of cartilage restoration. It's very, very rare. So this is just an example. This is sort of a modification of de jures. So the flat, this is a convex proximal trochlea. It's elevated. You're using a burr to thin it out, so it's a composite thickness of about 5 millimeters, and then just putting some sutures across it, which pull that down. Now you can see that we have a gentle slope. So I'm not trying to make a normal slope. I'm just trying to have a somewhat of a groove. Now, if talking about cartilage restoration, Rafi Mazarian has come up with actually doing a mega oat type of trochleoplasty. So he just throws away the old trochlea and puts in a new one. It's a huge oat. I think those are like 25 and 30 millimeter plugs. It's very daunting to be able to get everything matching up. This is a patient of mine that had dysplasia. And you can see the outlines. Those are eburnated bone on both sides. It was a flat, and patella had the same thing, panpatellar exposed bone. So I also did, this is a quote trochleoplasty, but it's really an osteochondral bipolar transplant. Lateral retinaculum, it controls lateral displacement after MPFL. I'm going to say this again, lateral release should not be done for first-time dislocators or repeat dislocators. So it's very important. Lateral release decreases the tension in the lateral retinaculum, but does not decrease load. I see this all the time in operative notes on patients that have failed lateral releases that comes in and says, the patella was tilted. Guess what? All my patellas are tilted arthroscopically because I got fluid in there. And so I did a lateral release to unload the lateral facet. Well, that's not what you're doing. You are decreasing the load and tension in the retinaculum, but not the patellofemoral. Excessive lateral release can lead to medial patellar instability. That's really a problem, especially if it hits into the vastus lateralis. And I would suggest use of a lateral lengthening that allows not only balancing the medial and soft tissues, but you're not losing control, and you can also seal the joint. This is the lateral retinaculum. It's a little busy slide. This is Mercan's work that he did at Andrew Amos's lab. He's got about 11 different layers here. John Fulkerson is more surgically oriented and designed a 2-layer. So basically, what you're looking at is an oblique layer to the left. That's the oblique fibers that come up from the IT band. What I've done is incise it adjacent to the patella and then dissected it from the deep transverse fibers, which are the next deeper layer. So we take all those multiple layers and just say, here's a superficial and here's a deep. So then we cut into the deep layer, and now the top is actually the deep transverse, the bottom is the superficial, and then at the end of the procedure, you can reattach those. And most of the time I can get 1.5 to 2 centimeters of lengthening. Thank you very much. Any questions? So Tom, do you want to oversee the vignettes? Brian is the first one with Marostim.
Okay. So we're going to do what we call video vignettes. It's kind of like a how-to session, how I do whatever we're going to do. So we have marrow stimulation, osteochondral autograft, those two topics. Brian will start with those. And then I think the juvenile allograft cartilage, are you doing that, Jack, or is Andreas going to do that
He's
one?
going to do juvenile. I'm going to use the cartilage.
Okay. And then we just move on through our schedule. We do have a break right now, but seeing as we're just a few minutes behind, why don't we let Brian do the two, and then we'll take a break right after there if we're caught up.
Okay. Can I get one of the AV guys just come down and make sure I can plug this in? Thanks. So I was asked to do, these are sort of quick vignettes on specific procedures. So I could do a microfracture video, it would take me about 45 seconds. So I just give a little background. And because I think it's more about the decision making, and there are some technical aspects which are important to get it right. The first thing is I'm not speaking about what's on the left, which is arthritic change. I'm really talking about the same things we've been largely speaking about, which is far less common, but obviously a clinical problem, deriving an entire day of discussions about it. So it's the localized defect that we're speaking about. And I've already told you about this paradigm of the easier the procedure, the higher the frequency, and so forth. And microfracture probably is somewhere in the neighborhood of 100 to 130,000 per year if you look at recent supportive data that's available. And I typically use marrow stimulation in this box here, which is first-line treatment without subchondral change. And maybe as they get a little bigger, between 2 and 4, I may add something like biocartilage. There was a recent, we'll call it level 5, I guess, article. It's an opinion, but it was interesting and it was provocative, and it led to some discussion about, is microfracture still relevant? And if you go back to Lonnie Johnson, abrasion arthroplasty, the results are actually fairly compelling, but it's a hard procedure to perform and control for bone depth and so forth. And the problem is that the studies really do lack a debridement control group if you want to look at marrow stimulation. And those that do suggest a comparison sometimes show equivalent results. And the challenge with marrow stimulation is that the subchondral bone is compromised, so that can lead to some downstream consequences. And then I would agree that there's plenty of data that shows that the results deteriorate over time. But the flip side is there's probably as good a data for marrow stimulation as there is with other high-level cell-based techniques. That's the irony of it all. The comparator by the FDA in and outside of the United States has been marrow stimulation. And there's a number of level 1 studies that, like it or not, have showed marrow stimulation to be have competitive outcomes. The other thing we know is that smaller defects do respond better. So we sometimes say 6, but I would say the cutoff is probably better to be at 4 if you look at the literature clearly. We also know that younger is better. And I think with most cartilage repair procedures, although we recently published with osteochondral allografts that age didn't seem to make much of a difference, but I'm really conservative in terms of who I might do an allograft in if they're over 35. So that was my population of patients. But most literature does show some age-related differences around the cutoff of 35 to 40 years. There's also literature that shows that marrow stimulation could work in athletes, and these are typically athletes with smaller defects. And again, these are level 4 series, right? But suffice it to say, much of what we're making these conclusions on is level 4 data. That being said, small defects, short duration of symptoms, femoral condyle has some compelling outcomes, even in higher level athletes with marrow stimulation. So then you have to say, well, why are we failing? I think we're failing in part because the indications can be wrong. I think there are absolutely technical aspects of this procedure that are important. Stedman used to say, you guys, the reason you're not getting the results I get is because you don't do it right. We sometimes, well, how hard can it be to poke a few holes in the bone? But I think the most important thing is the rehabilitation, and I'll tell you why. And obviously we have these considerations, and Tom and Andreas' work and a few others have showed that there may be some downstream consequences of marrow stimulation. The first argument I would make is that when you look to the literature, and most of you in this room who perform marrow stimulation, you do it in isolation. In other words, we tend to talk about comorbidities like malalignment and meniscal deficiency and other things when we speak about these expensive technologies. But when it comes to marrow stimulation, it's the first thing we pull out of our hat, and we do it sort of without consideration for all these other comorbidities routinely. So I would submit to you, if we place the same amount of rigor for marrow stimulation as we do for these other techniques, we might see similar outcomes. There's no question that subchondral bone changes are present both in humans and in animal models. I completely agree that this is a finding. There's different animal models that show different prevalence, but osteophyte cysts changes are very, very common after marrow stimulation, both in preclinical and clinical studies. The other thing is that from a technical perspective, this is a study we did not long ago where we essentially looked at the ability to prepare the defect. And what we showed is that independent of the level of training, arthroscopic preparation, if you believe removal of the calcified layer is important, was actually less reliable than doing it open. So one of the challenges is we just don't have all the tools necessary in your operating room to do a good job, and people did a better job when we looked at micro CT in preparing the calcified layer, if we think that's important, when we did it open versus arthroscopic, and most of us do not do marrow stimulation open. This is Bob Salter shortly before he died. Lovely guy. I had a chance to talk to him, and he says, the thing that people forget about and the things that I looked at in the animal models in the rabbit was that it was either motion or load. And if you could load marrow stimulation and not cause any consequences, that too would be good. Things would probably be better just given Wolff's law. But we have to restrict the load, so we do motion instead. But if we could load it would probably be a good thing. So this is these are videos that you see a lot. Lisa, this is from your lab, I know, or from people at your institution. The only picture that's reproduced more is Steve Arnowski's picture with the blood vessels going into the meniscus, so you should be proud. You're getting the same number of hits, almost the same number of hits. So this is serial CT scans that are stacked on top of each other, and it just shows you in a very sort of simplistic way that microfracture is causing a fracture, right? So what happens in a fracture? There's a response that's a fracture response. So if you load a fracture like we generally like to do to induce healing, as long as it's a stable environment, you get sclerotic change, you get calcium deposition, you get callus, and you get these things that we talk about, cystic change, subchondral change, and this is a picture from one of Andreas' patients showing bone accretion in the center of a defect because you caused a fracture, and that's what happens. No surprise, right? So that's why I think the rehab is actually particularly important in this patient group. Tom talks a lot about this issue of prior treatment. We didn't see in the STAR study, which was a multi-center study, in those who failed initial treatments, that those who had marrow stimulation did worse with microfracture. It's a long discussion. I'm not going to have it here. We looked at in our osteochondral allograft patients to say, is there something unique about that population? Because I think there's a population that no matter what you do, they don't get well. So we were interested in saying if they failed marrow stimulation, then can you do okay if you do an osteochondral allograft? And suffice it to say, we actually did pretty well when we revised our failed marrow stimulations, and it wasn't a negative risk factor for outcome when we did an osteochondral allograft. So just food for thought. Okay, so gentleman asked a question before about drilling versus awls and so forth. I think why are we penetrating the subchondral bone? If you look at Lonnie Johnson's data, you probably can do okay with abrasion arthroplasty, but technically we have challenges to get it right and not cause an undulating surface and too much violation of the bone. So then we use an awl, which is inexpensive and pretty reproducible, but it's probably, as those stacked CT scans I showed you, much more traumatic to the surface and much more of a fracture response. So my personal position is that, forgetting about this discussion of thermal necrosis, that it's probably a good idea to get away from this traditional model. So this is a video that Stedman provided me, and others use this, where he shows the technique. And this is the classic technique as described, which is do a debridement. He didn't speak a ton about vertical walls. I went to visit Dick before he retired, and I kind of joked that this is about a 45-second operation. It was probably no less than 45 minutes to do this operation. Okay, this is a highly edited video. And nonetheless, I was sort of underwhelmed with the amount of time that was spent to create a vertical wall, but he did a really good job getting rid of the calcified layer. Just upon retirement, he and Bill Rocky said, look, the number of holes matters and more holes are better. The concern I would have with that paradigm is that the more destruction you do to the bone, the more fracture response you're going to get and the more potential downstream consequences. You have to ask yourself, why are we even penetrating the bone? Same reason Lonnie Johnson penetrated the bone with abrasion arthroplasty, to presumably take advantage of the host's ability to heal with MSCs or other, right? So we're just trying to get bleeding to the surface without causing any downstream problems. And then typically after marrow stimulation, we've all seen this kind of repair tissue. You get something like this. And for many it's enough, and for others it's not. So when you take into consideration drilling, these are there's several companies that have the ability to drill these lesions. And the top I show you pre-microfracture, then I see you post-microfracture on the right, and we often see with early MRI these MRI flares. If you look at the bottom, that's after drilling. It's much less exciting than the subchondral bone. I don't think this gets you away from having to protect the patient post-operatively, but I think there's less damage that occurs to the subchondral bone when you drill it. So this is just another video now showing sort of what I think is a contemporary technique, creating a vertical wall. And I think, don't be fooled, this can be difficult to do, to get this perfect. And as I showed you, we don't do as good of a job when we do it arthroscopically versus open. But you want to get through the calcified layer. That's some work that was done at Colorado State, looking at various models. They believe that in their findings that we get better repair tissue if you get rid of the calcified layer. And then I do this under power. I space them about 3 millimeters apart. I avoid confluence. And this shaver I used there is pretty atraumatic in terms of chondrocyte death, and it gets a smooth wall. So always trying to get a vertical wall that even if you don't get good repair tissue, you turn a defect into something that's biomechanically superior. The surrounding area does a better job at sharing the load, and that's stuff that we've proven by micro-CT and load assessment. So there's a bunch of little tools that are available to suck out the fluid, and I can tell you all kinds of little tricks, but this can be done arthroscopically. So that was the microfracture. Now we're just cleaning the defect with a swab that you can put suction on, and you can use this metal cannula that has a little paddle on the end to introduce, in this case we're using biocartilage, we mix it with PRP, and put it into the defect. Now, just keep in mind that I think the reason, if you're going to be interested in biocartilage, this is a scaffold that is saturated with something that's maybe inductive, all right? The scaffold goes away. So when you do this, you say, well, let's just fill it up because it looks great, and you hope that it all stays there, and you're looking at it as a transplant. That's not the way this is likely working. If it is working, it's carrying something to the area, keeping it there a little bit longer than it normally would if you just did an injection, and then it goes away. So the fact that it's a scaffold that may have some growth factors and matrix that's articular cartilage may or may not make a difference. We haven't shown that, right? But I think at the very least, the benefit comes from it acting as a scaffold to put something in there that you think will be advantageous to the biology. And you don't want to overfill it, because the first thing that will happen is the fat pad will catch it and it'll just pull the whole thing off, and then we put fibrin glue on it. So the rehab, we do CPM for 4 to 6 weeks. I do that religiously. I protect their weight bearing for 6 to 8 weeks. This is the only procedure I do where I protect weight bearing to this extreme. And then we're typically looking at return to sport at 6 to 8 months, because if they really need the results of this operation, that's how long it takes to get well. So is it as bad as they say? Right or wrong, marrow stimulation is still the primary comparator to virtually every other cartilage repair technique. I still think it's very simple, it's cost effective. The literature supports that smaller, younger, symptomatic lesions, that when you take into context of comorbidities, you can do very well with this. It's technique and very rehabilitation sensitive, much more so than any other procedure I think we do, maybe even more than cell-based techniques. I use a drill rather than an awl. I'll even use it in athletes, and I believe they can return to sport as a first-line treatment, and certainly it's cost-effective if money matters. Thank you very much. So real quick, I'll just give you an update on oats. I don't, admittedly, I don't do a lot of oats, but you need to know about it because it's part of the treatment armamentarium. And again, just like apples and oranges and marrow stimulation, there are two ends of the spectrum. One is a large number of small diameter plugs or a small number of large diameter plugs. And where does it fit in? I don't know if we have a good handle on how often this procedure is performed. I've seen numbers around 12,000. I find that actually hard to believe, quite frankly. The problem is people use the oats instrumentation for lots of different things. So I suspect that the number is a fraction of this when it's being used to treat articular cartilage disease. Where does it fit in for me? Those defects that are around a centimeter squared, I think the literature is very supportive in high demand patients as a first line treatment. It's an intact organ. It goes on for osseous integration. It restores the anatomy, and it can be done in a single stage. I would say that these are the relative contraindications, like any other cartilage repair technique that we're trying to do. There are essentially three manufacturers in the United States that I'll just show you briefly. They're generally disposable systems. This offers a number of small diameter options that are drilled. Another one that basically same kind of concept, various diameters that are put in by hand. And then another one that's reusable in this case, and you harvest using power. So these are the various systems that are on the market. It can be done either arthroscopically all the way to open, and I would advocate that you harvest open and you put it in if you can arthroscopically, but if you have to make a small incision, that's fine. This is the basics of the technique. Determine the size of the defect, determine where you're going to harvest your donor site, extract your recipient, and then put the plug in. Sounds simple, but it's actually probably one of the more difficult operations to make it look good. You can spend all the time thinking about this, but in the end, many times it just doesn't look perfect. So as far as, oh, interesting, okay. Well, that's fun. Why is that happening? Hang on. Tom wanted this to be a video. Wow. All right. Okay, hang on a second. This will be fast because there's only a couple of videos and we're done. Cartilage. Okay, not going to happen. So why don't I just show you the technique? Yeah, but that's not that video. So it's going to take two. I don't know why that happened, but let me see something. Maybe. Forgive me. Oh, it's bizarre. All right. So basically what I'll do is measure the defect and do that arthroscopically and just take a spinal needle as a trajectory. That's it. Now, the one pearl, if you're coming to a medial femoral condyle defect, if you think about the orientation of the medial femoral condyle, you can't use your medial portal. You have to come at it almost through the patella tendon. So that's just a little pearl. You're going to try to just do two portals, and it just doesn't work because you're not getting orthogonal or perpendicular to the surface. So that's pearl number one. And then where do you take your donor? So this is where you don't believe everything you read. We published an article that you can take it from the medial side because the contact forces medial are lower than lateral. The challenge is there's not a lot to work with on the medial trochlea. So even though we publish this as a possibility, I never do it. So to be honest, what we generally do is if I do this operation, I don't take it from the intercondylar notch because I don't do this for tiny defects. I do it for 10s and 11s. So I take it from the proximal aspect of the lateral trochlea. I still do it that way, and I go very far proximal when I do that. Then we harvest, just as now the next pearl is do this mini open. I don't know how anyone could possibly do a harvest from the proximal lateral trochlea arthroscopically because you've got to get the patella out of the way. So what I do is make a very small incision, put an Army Navy in there, and don't cantilever the Army Navy, just pull it straight medial so the patella goes medial, and then you get exposure to the proximal trochleus. So yeah, the proximal trochleus. So you basically you have a very tough time doing this arthroscopically, and I harvest my plug first, then I just put a clamp or a stitch or something just to close it off so you get occlusion, because I generally put it in arthroscopically, okay? I don't generally backfill with any synthetic or anything. What I will do is take the donor plug and just pound it into the recipient socket, to the donor socket, forgive me. So let me restate that. I take the recipient plug, the place I'm trying to repair, and I put that in the trochlea. It's about 1 millimeter smaller, so it wobbles around, so I just pound it in. I never had one dislodge. Then I do this part arthroscopically. So this is really the technique. And it looks easy and fun, but I'm going to tell you that about 50% of the time you're off by about 15 degrees or so. And I don't know if it's a function of the instrumentation because you don't get a flat bed. You think you're orthogonal and you're not, but don't get too frustrated because it's very easy to still be off no matter how much attention to detail, even if you do it open, quite frankly. But the place where you get in trouble is after you take the plug out, look at the base of your defect, because I think what happens sometimes is the bed kind of fractures and it's not all the way across and there's a little bit of bone remaining. So what you can do, if you look, you see the bed there. So maybe take a tamp and try to get it level before you put your plug in. And if you have to have a millimeter mismatch, that might help as well, so you can get the plug not recessed, but flush. So here we're just taking a tamp and making sure it's flush. You never want to pound on this plug because I think that's why the early failures were occurring, because they just delaminate. So the plugs themselves really don't take a joke. If you hit it with a hammer or a mallet, it's going to deteriorate potentially over time. And these are small pieces of cartilage, so they really are much more fragile than even an osteochondral allograft. So then we just insert it under just hand pressure, ejecting it with a screw device, and then we gently, if possible, tamp it into place. If you dilate a little bit, it'll go in easier. And I typically just use one plug, that's it. Because I'm not treating large defects with this in my own personal algorithm. But there are places where guys are using multiple plugs and they're getting good results, and those are out there. But my own personal algorithm is failed small defects for neurostimulation or a higher level athlete for first-line treatment. Again, what about the rehab? Different than neurostimulation. I think you can partial weight bear these people initially. It's very stable. I'll use CPM, but I would argue maybe it's not that important because it's an intact organ. Certainly doesn't hurt. I wouldn't obsess if you can't get CPM approval. I think getting them motion early on is good. I don't use a brace if you don't need it because it's just more hassle for them. And then typically where I tell you return to sport for neurostimulation is 6 to 8 months, that's because that's how long it takes to get them back, to get them to feel well. For this, I generally see them feeling better sooner, and it's somewhere around 4 to 6 months. So results overall, there's a couple of very good comparative studies against neurostimulation showing that OATS does actually better than neurostimulation. So in summary, smaller lesions, there's a couple of instrumentation systems available. I don't have any biases, only to say that I use the largest size harvesting system because I'm usually treating 10, 11 millimeter defects. It's not as easy as you think. The results overall have been quite favorable. The residual concerns are chondrocyte survival. That's usually my number one reason for revision. I go in, the plug is delaminated. They are very sensitive to impaction. We and others have shown that, much more so even than an allograft. And I think it's because of the size. And frankly, I think the bigger challenge is, why does a 1 centimeter defect hurt? So I don't do this frequently because I just don't see a lot of painful 1 centimeter defects. Thank you very much. Time for a question. Tom.
I enjoyed seeing that microfracture technique with the cartilage case on. So my question is,
Thank you.
it looks so enticing how a repair tissue heal from time zero. When do you microfracture alone?
Yeah, great question. I get that asked that a lot. So Tom's question is, when do I use neurostimulation or neurostimulation plus biocartilage? Okay, so it's not free, but it's a lot less expensive than other things we do, and we do have some reimbursement challenges. So I don't use it every time I do neurostimulation. If I have it's primarily cost and hassle driven. It's more time, it's a hassle, and it's not a huge hassle, but it's enough of a hassle that if I can do less and get the same outcome, or believe that I'm getting the same outcome, then I'll do less. So the short answer is defects are in the 1 to 1.2, 1.5, I'm just doing neurostimulation. If it's bigger, the ones that have challenged the outcomes in neurostimulation, where I still want to do neurostimulation, those are the ones that I will use biocartilage. Does that make sense? So, that's my answer. It may not be rational. You say, if it's so good, why not use it for everything? But if it's a tiny defect, you're delivering just a tiny amount of PRP and BMAC there, right? So I don't know. I don't know that it isn't worth it. I just don't have enough confidence that it is worth it. So I don't do it for the small ones. No, how big will I go? I don't go any bigger now for marital stimulation than I have in the past. I still keep it no bigger than 4. But I really just don't necessarily believe I have the confidence in that procedure for larger defects, based upon what I think I know. So it's generally 4 or less, and I have to have all the other things line up. Yeah.
So the second question is, with the Oates procedure, your donor site, so why use the proximal lateral trochlea versus the distal lateral at the sulcus?
So why use proximal lateral versus distal lateral? So intuitively, when you look at how the patella tracks, it starts out right where I'm taking my plug, and then it goes distal medial, right? So when you've, just to make sure, that's how I always think about it, right, Jack? So the patella starts out proximal lateral, and then goes distal medial, which is what made us think, let's take it from the medial trochlea, because you've got high degrees of flexion, and you've already moved past the medial trochlea. And that's what we showed in our contact pressure studies. I do it because I look at that area, I'm like, how could this possibly be important? I take it from the proximal lateral, you're right on the edge where that synovium is, and I take it as high and proximal as possible. It just looks, to me, that it just looks so weight-bearing to take it near the sulcus that I just don't want to do it. So I just stay really high and lateral. It just seems to me intuitively that it's a better place to take it. I don't know that it's better. And I haven't had any donor site issues, to my knowledge.
Yeah, I do the opposite. I go distal lateral. I take it at the sulcus. And when you put them through a range of motion, the patella almost never comes across
What about the
the
tibia,
donor
though?
site.
What about hyperextension of the tibia? It doesn't
Yeah,
come close?
so what I do is I bring the knee to full extension, and I make sure it's just anterior to the anterior horn of the lateral meniscus,
Yeah.
and that's where I take it.
I think probably fine. Yeah, if you err too distal, it's going to be a weight-bearing zone and extension.
Right.
Yeah.
But the other thing is you don't have to do it open. You can do it through the scope.
That's true. I agree with that.
Yeah.
Absolutely true. That's a great point. You win. Okay. Anything else? All right. Andreas, you next? Or Jack? Jack's next. Okay.
Oh, okay, they switched it up. So this is going to be, do you want to turn it on?
I will be presenting a case of cardiform allograft cartilage.
You can turn the volume off. I'll just talk through it. So this is a case of, this is the cardiform that we heard about before, 27 years old, very active, noted onset of pain in 2012 and progressively had pain to the point that he had to stop running and even cycling, retropatellar pain. You can see his patellar lesion at the region of the apex. It goes deep. There is some subchondral bone changes with stress reaction. So this is approach. You can approach these that certainly go through a lateral lengthening, and if you have adequate exposure and the lesion is towards the lateral aspect, I would just do an isolated lateral approach. I showed this earlier, so I'm getting about 1.5 centimeters of lengthening. In this case, I wanted to be able to examine the entire patella better, so I'm using a medial parapatellar arthrotomy, everting it. This is like you've seen over and over the other cases. You're saying, well, this looks pretty good. This is a very small lesion. But this had already been evaluated with staging arthroscopy. And so we just do very slowly going around and creating vertical walls, like you've heard time and time again. It starts out small, and then we assess the margins. And if they're not stable, then we go a little bit more. And so this lesion is going to be on the order of 20 millimeters after it's fully debrided to vertical wall. In this particular case with this cryopreserved cartilage, you can either use microfracture or superficial abrasionoplasty. I have such respect for the subchondral bone plate that I don't do microfracture. Typically, I'll just do the Lanny Johnson very superficial abrasionoplasty till I see punctate bleeding. Doing a template like we do for a lot of the different patches that we have, especially if there's different, this is kind of an oblong one, so I want to make sure I have the appropriate match. You can see there is a little dent or a little line that shows the side that goes towards bone, and then I'm just cutting this. So this has been thawed and rinsed. So now we'll put the bone side towards bone. This construct does actually have microscopic amounts of bone at the base. We're typically using 4 knotless suture anchors, or in this case, you can use suture anchors and tying knots. In some of the lesions, if there's ballottement, I'll use a single one in the center. This one did not ballot, so it was stable. I'm just going around making sure that there's not going to be excessive micromotion. I think that would certainly interfere with healing. Then I'm just sealing the margins with fibrin glue. Why are we doing that? That's the way we were instructed to do. This was as part of an ongoing prospective evaluation. That's with it in place. I'm just repairing the lateral lengthening. This will show you how much lengthening you can achieve. And we'll be able to seal the joint with this as well. So there's the first incision, and then you can see where the suture lines are. So in this one, it's probably about 1.5 centimeters. Those are the anchors that you can see in place. And this shows you there's good basilar integration. And this was in the depth, so it's only 1.5 millimeters thick, and yet is actually increased in the thickness compared to preoperatively. So I do agree that the marginal integration is incomplete. Thank you. Do you have the juvenile in the NT? Are you going to do that?
Let's see what comes next.
Yeah, whatever comes up next, we'll just talk about it.
No.
We don't want
Do you want me to pick it?
Yes.
So this is dead,
No, live.
so fresh frozen, right?
No. So there's all these names. They have to have cartilage in them, so they're all very confusing. So there's cartiform, and then the one that Andres and I showed that didn't work is chondrofix. That was dead cartilage.
Zombie plug.
Frozen cartilage. That was the allograft. This is also allograft. So this is live osteochondral allograft. They take a plug, just like an allograft plug, and then the technician takes away more and more and more bone until you really can't even see it with your bare eyes. There's enough there, you can detect it, and maybe that's better for basilar integration. Then the people that started this company, Osiris, many of them came from CryoLife. So they're very experienced and had a lot of failures with cryopreservation, but they think that they have perfected it. And Lisa and I were just talking, the basic science on it looks like at the time of thawing, they have at least a 70% cell viability. So it is living cryopreserved cartilage.
Because before this, the best they could get with all the different methods was about 5%
Yep.
cell preservation.
That's
70% of the cells were alive.
Yep. They have the live dead assay stuff, so they think people can lie, but I'm just, yes. Good. Pardon? Could you speak up so Tom can hear you?
They're using what's called a vitrification process. So it's more like how you go through the process of freezing a human embryo. So the data's real. It's truly that viable. It's cool.
Jeff, what do you think of the process of it filling is?
It has a bunch of holes in it, so it's perforated. And so they've done a couple studies. So I have one slide where we have de novo NT, which is like the donut holes, and these are sort of like the donuts. So we've seen both with de novo NT and with case that at a certain size, and it's about 2 millimeters cubes, the cells can exit, migrate, multiply, and form extracellular matrix. So we've seen that. Yes. So we don't know, but you can make a good story for either one. Dan Saris is adding stem cells to chondrocytes, and the chondrocytes are telling the stem cells and associated what to do. Codone, a long time ago, did something similar where the chondrocytes appear to kind of direct the local topology. So they also did an elution study, and there's a lot of cytokines, chemotactic factors that are eluting out of this at the same time. So I think it's probably all the above. Lisa?
I think the other really cool thing about this is it provides immediate biomechanical integrity to the loop stresses in the surrounding cartilage. Unlike all the other, everything else that we've talked about, this provides immediate biomechanical strength to the surrounding side. The appropriate biomechanical strength that's cartilage.
Yes. Well, they did this in an animal study first, and it didn't exhibit that. And then with the first humans, they looked at, Lisa, you must know some.
I'm forgetting the young man's name, but he actually came to you as a traveling ICRS fellow, and he did all kinds of, for sure, you're going to get apoptosis about 4 cells into any cut surface. And I wish I could remember this young guy's name. He's published this on how it has to be like super sharp, and that's how they come up with that little chopping device. I thought it was a complete joke when he came with this like slice or dicer thing, but there's far, far less cell depth. And it's about, it's the thickness of the blade, the sharpness of the blade. Right here, I thought the same thing was came on late.
Well, I think that part was probably David Bonaccia, right, from Turin. I think. It's David Bonaccia. He worked with Ned Amendola, and he's from Italy, and because they were doing quite a bit of this stuff even before it was published.
Yeah, I thought it was a crazy resident idea, like, don't pay fine, but it figured it out.
But your point is very well taken in that the smaller you make them, the more it's easier for the cells to get out. But the smaller you make them, then the surface damage is greater. So there's a diminishing return, and that's why it's probably in that order of 1 to 2 millimeter cubes, where you have acceptable amount of cell death and still have remaining cells that are alive and able to exit, multiply, migrate, and form matrix. Can you turn on the video, please? So this is the de novo NT. This is
a
particulated.
case of
You
particulated
can turn off the
cart-
volume. So this is the juvenile cartilage that's minced and stored. So this is an osteochondritis dissecans of the central aspect of the patella. You can see this is not repairable. So in this patient, we're doing an arthrotomy. The patient had a previous procedure to that area. It was a marrow stimulation procedure at an outside facility. So this is just a painful arthrotomy here. The preparation is just the same as all the other cell therapies. So you want to have a nice, healthy vertical wall all around. So we're making that with a 15 blade. And we're being generous. I mean, if I have to take 2 more millimeters to get to very healthy cartilage, I do. Now, in this case, it was osteochondritis dissecans, and there was dead bone at the base. So I'm just irrigating my burr until I can get down to bleeding bone. You can see it's fairly deep, 15 millimeters. The lesion measures about 15 by 20 millimeters. And now we're at the base. I still don't trust osteochondritis dissecans bone even when it bleeds. I've been burnt a few times, so I drill it. Then here I'm going up onto the femur and using a harvester. I'm just harvesting some autograft cancellous bone. It looks like there's quite a bit, but it takes every bit of that Now this is I'm just backfilling the harvest site with allograft cancellous bone, and I'll just repair the periosteum overlying it. Now I'm taking all that autograft and placing it in. I did mix that with fiber and glue, and I'm compacting it. This is how it comes packaged. So this is cooled but not frozen. I'm taking out the transport media, just leaving a drop, just it makes it easier to move the cubes around. In the study that we published, I tried to get the chief scientist from Zimmer to give me permission to tell an exact number or the spacing of those. I think it's important, the closer the better, because it takes less time for the cobblestone effect to disappear. So I'm using typically one packet to cover 2 centimeters square instead of their recommended 2.5 centimeters square. You can turn it off now. Any questions on this? You've heard about it before, so this is just the live technique. Yes, Tom? So well, I had one case where I actually not only had the MRI, but I also had second and a third look. It was an unfortunate case where these were sent to me. And he was supposed to have something else. Oh, a meniscus transplant, and this was a trochlea. So I said, we could either throw these away or, we can have 2 surgeries. So he elected to have them put in. So I got to see it day 1. Then I did an HTO and meniscus transplant on him. So I got to see it when I did that. And then when I took out the HTO hardware, I got to see it again. And it looked very much like some of the horse data with case. So it does very much look like a cobblestone with some white stuff in between, and then gradually over time it fills up. But it takes a long time. It takes almost a year. Do you think the
tissue, the cells actually migrate, or do you think the cells act more like stem cells that they cause?
Yeah, I think once again it's a combination, and we know so little. We're just kind of out there in the dark. But so I did about 90 of these at one point, and I did biopsies in plus or minus 10, and I have biopsies that look so good you would think I biopsied the native cartilage, and I have biopsies that look so bad you say, well, that's just fibrous tissue. And most of them were a mixture, and you're used to seeing this, quote, hyaline-like cartilage pattern. So I didn't feel like, oh, this is so much better or so much worse than other types of cell therapies that I've seen. Very, very analogous.
Next one is on osteochondral allograft. Let me just see if I can find that. And can you make sure that the sound is turned off for that as well? So first I want to say thank you. I don't see where they are. Alex is here and Jacob is somewhere else, my research fellows that filmed this and put this together. So we haven't really talked much about osteochondral allograft yet. So what is it indicated for? It's really for the larger lesions. Historically it's been used to reconstruct osteochondral defects. So anything where you need both the cartilage surface and then the foundation underneath to be repaired in a single step. This is something, as Tom had mentioned previously, that he uses for AVN. I think for AVN it's a great indication because oftentimes these are younger patients that are not really candidates for total knee replacement. And the AVN in the knee is not like the hip AVN where you have alcoholics, not necessarily patients that would behave well. These are mostly kids who had bone marrow transplant, had high-dose steroids because of the bone marrow transplant. So a little different patient population than the hip AVN group. What's nice about it transfers mature hyaline cartilage. So other than cell-based therapy, there's nothing really that needs to grow over time, firm up, decide what it wants to become. This is hyaline cartilage. It stays hyaline cartilage. Replaces the entire osteochondral unit and it's primary bone-to-bone healing, which in comparison to cartilage is pretty straightforward. evolution has taught us how to heal bone pretty well, just haven't gotten around to cartilage yet. How do you preserve it? There's fresh. That doesn't exist anymore. So fresh, in the old days, Alan Gross, they essentially harvested from organ donors in their own hospital, and then within 1, 2, 3 days re-implanted it. There was no checking serology, bacteriology. It was just taken out, put back in, the same you do with kidney transplants in a way. And they didn't really have many infections, so it's an okay thing, but the FDA currently does not allow us to do that. You need to do extensive testing, and because of that, we have moved to the prolonged fresh. That means for 2 weeks, they check viruses, bacteria, spores, make sure everything is okay, and once all those tests come back after 2 weeks, then it gets released. By FDA rules, it's good up to 6 weeks. If you look at viability data, it really starts coming down after 28 days. So for the most part, even if the transplant company would release the graft up to 6 weeks, after 28 days, I say thanks, but no thanks. So up to a month is okay. There's fresh frozen. That is dead tissue. So maybe you can use it to backfill oats harvesting sites or so, but not for primary cartilage repair. And then cryopreserved, Lisa had mentioned the old way of cryopreservation, not many living cells. The new, I don't know if you can do bigger grafts like this, maybe that's an option, but currently we don't really have that available for larger structural grafts like this. So how do you do the technique? And I'll show a video to follow, but ultimately you get something that is size matched. It doesn't have to be as closely size matched as a meniscus transplant, but it needs to be somewhat in range, and for this one, bigger is definitely better. You don't want to be in an OR, have decided that you need, let's say, a 26 millimeter plug, but the condyle that you have is only 22 millimeters wide. Then you're a little screwed. You can do a limited arthrotomy, so generally they're fairly small incisions, unless you need to do other things like osteotomies at the same time. And you want to minimize the amount of bone that you have. So generally the composite thickness is somewhere between 6 and 8 millimeters. This is not something where you want to go deep like an oats plug. You don't need that for mechanical stability. And even though cartilage is immunoprivileged, so there's no rejection to the cartilage itself, the bone and the bone itself is fine, but the bone marrow contained in the bone, that is not immunoprivileged. So there is a little bit of an immune reaction to that. And Bill Bugbee has shown that the larger the graft, the more bone marrow is left in the graft, the higher the likelihood of you forming cytotoxic antibodies. Now, clinically, we haven't really found that to be an issue. And these things have been put in for over 30 years. People have had babies after this, organ recipients, so you can detect them, these cytotoxic antibodies, but they don't seem to do anything. So the technique, you take the graft from the corresponding area on the donor condyle, you measure the depth, cut the graft accordingly, and then you press fit it in. So similar to what Brian had said about the oats, you don't want to hit this very hard because you kill your chondrocytes if you expose them to undue pressure. And then the image on the right is an arthroscopy. It's a second look, I think after a year or so, to take out some screws, and it's almost undetectable where the graft is. This is the graft, this is the native cartilage, and that's the seam. That seam never closes. I've never quite understood why these don't close, because we just heard about de novo, about the cardiform. You have outgrowth of chondrocytes that can form repair tissue. Somehow there's no outgrowth of chondrocytes in these. Not sure why that is, it's just an observation. Complications, it's most of the time actually not the cartilage that fails. That makes it different from our cell-based therapy. It's the bone that fails. So there's incomplete incorporation, and there might be some subclinical immune reaction where at some point the body realizes the deeper it goes into the graft, the more bone marrow it encounters, because the deeper in the graft, we have trouble irrigating that out. And then at some point, it just stops integrating it, and it turns into what is essentially an OCD lesion, which you can see here. So on the surface, you can say the cartilage doesn't look awesome, but more or less intact. As soon as you start playing around with this, you see it's an OCD lesion. That piece is dead bone that needs to be revised. So now to the video part. This is a 38-year-old we operated just a couple of weeks ago, had disabling anterior pain, but also medial knee pain. He had a failed microfracture in the trochlea, and he had quite extensive medial-sided disease. Surgery, I don't want to spoil it too much, but So if you look, I don't know how well you see this, but he had medial arthritis. So for that, he would, given his young age, be not a candidate for arthroplasty, but we did an HTO for that to address his medial disease that was a little bit too far progressed to do anything cartilage repair there. But he also had an old trochlear lesion, which in the past had been treated with microfracture. I don't know if you can see that, but right in the center of the trochlea, there's an area of, great, if the rest is like that, it will be a little psychedelic experience. But there's an area of microfracture right in the central trochlea that he still had symptoms from, and on the MRI scan you saw some subchondral edema. See if we can rescue this. And no. So, what you would see, if you can stand on your head. So, sorry, that always happens when you take something with iPhone and you don't have the right codecs. Since the whole presentation will be like that, Tom, is there any sense in still doing that break? Well, can you see anything? Well, we can try and do it on a different computer, but this is not very useful, I think. Just why don't you do that? Why don't you do yours, and we see if we can fix that in between.
It makes no sense for us to have a break as opposed to just moving forward, finishing, and having our cocktail hour. So there's wine outside for all us out here. So why don't we just finish these two talks and talk over their glass? So I'll just move on to my talk, and Andreas will close it.
Maybe. This is just...
Okay. All right, can we just put on the sandwich ACI talk? Is this it? Minus 430. Yeah, that's it. Thank you. Okay, so I'm going to talk about the sandwich ACI talk. This is going to be our, just to show a little bit about how the technique is done. This is Lars's technique, which I adopted, and I'll go historically how this happened. So the technique, the reason it's called the sandwich technique is because the problem we faced is osteochondral bone loss, and we wanted to try to find a way in young patients to restore the osteochondral unit with autologous bone and autologous cells. So this used to be done in a staged fashion in my hands. I used to do this in a two-step. I would bone graft it, and then allow that to heal, and sometimes we'd have a fibrocartilage repair. Then I'd come back if the patient had persistent pain and swelling and do an ACI if necessary. And then Lars came up with this idea, well, why don't we seal the subchondral bone from the surface, let the tourniquet down, have a dry bed as we need for ACI, suture on a second membrane, inject cells, and we sandwich the cells between two layers of membrane. So that's why it became known as the sandwich technique. I thought it was quite ingenious, Lars. So my disclosure just before. So this is the situation we face. Osteochondritis dissecans, the shallow ones where they're sort of very shallow but deep in the middle, they often do very well with just ACI in isolation, and a lot has been published on that. However, when you have deep vertical areas, I think just filling this up with cells for defects that are 8 to 15 millimeters deep, it's a lot to expect that to fill with chondrocytes and form a new osteochondral unit. Avascular necrosis for the non-steroid induced, the idiopathic avascular necrosis, bone cysts, which can occur after microfracture or just sometimes just idiopathic bone cysts underneath the articular surface, failed osteochondral allografts, autografts, and failed synthetic plugs are the ones that we looked at. So the Landy-Johnson technique of autologous bone grafting to try to obtain a fibrocartilage repair was the technique that I first used for autologous repair using iliac crest bone graft or bone from the opposite side of the knee. If it was a tibial defect, take it from the femur. If it's a femoral defect, take it from the tibia. bone graft the area of damage. So what would be done would be I would undermine this like a dental amalgam, drill into subchondral bone to get a new vascular supply. This is after all the abnormal bone was removed with a high-speed burr, and then using the autologous bone graft, morsellized, packing it up to the subchondral bone plate, letting the tourniquet down, getting a superclot like a microfracture to the surface, and put that through a range of motion in the OR, and if it was stable, we were done. If any of the bone graft fragments appeared that they were unstable, we would just do a 6-ovicral suture net to hold them in place, and then rehab them with CPM as if it was a microfracture. So that was the technique that we started with, and this would be the superclot that would develop on the surface, and that was what I started doing in the early 90s. Lanny Johnson's own technique was written up 12 to 21 year follow-up, and when you look through the article carefully, you see this is what he used to counsel his patients with, and he would say that the treatment for large volume articular defects by this method remains salvage in nature and palliative in outcome, and he would caution his patients that swelling and some pain was to be expected if they were too active. Well, that doesn't work for my patients. If I tell them that they're coming to a joint preservation surgeon and I'm going to be limiting their activities, they don't take that too well. The other thing he found in his series of patients was that it did very poorly for avascular necrosis. Most of them went on to total knee replacement in a very short period of time. Where this was more useful was for osteochondritis dissecans. So the technique of preparation for ACI, here's the cavitary defect. We use a high-speed burr, and then we get a smaller burr and undermine the cartilage. We fill it up with autologous bone graft, fibrin glue, seal one membrane, and I would tuck it underneath the cartilage, let the tourniquet down, make sure it's dry, suture the second membrane, fill it up with cells. So that's our technique. We've changed a little bit the nomenclature, even more so from that. When it was the entire area of the bone that was needed, we'd call this a full sandwich. And if we found that a segment of the area, in other words, it's a large articular cartilage defect from here to here, but there was a cyst or something in the middle, this would be called a segment, a segmental sandwich. And then the third area we were using this would be for a patient who had completely abnormal bone, but it was shallow. We'd remove all the abnormal bone, for instance, a microfracture or drilling, or just a very sclerotic bone. We'd remove all the sclerotic bone, lay down a membrane, let the tourniquet down and suture it on, and that would just be called a sandwich without bone graft. So this is, can we just play this video? This is actually an opening wedge tibial osteotomy that I did. Here it's a retrotubercular one. We're just finishing the osteotomy. This is a varus knee with a large failed osteochondritis dissecans, and I'm just taking the autologous bone. I'm just injecting the soft tissues here with a pericapsular infiltration for pain. But this is just using a oats harvester to harvest autologous bone, backfill that, as Jack showed, with cancellous bone, and use the autologous bone for the articular defect on the medial femoral condyle. So we're just harvesting bone first. Here's the defect itself, the fragment you can see, and it's a deep defect, but it's got sclerotic bone on the backside. It's not amenable to bone grafting and repair, so it's taken out, and the abnormal bone is curetted back to intact cartilage, and then the whole area is removed with a high-speed burr under continuous irrigation, multiply drilled to get into healthy subchondral bone. And then the bone graft, this is a relatively large lesion and about 1 centimeter deep. It's morsellized on the back table here. And once we have it all morsellized, we then pack it in with a bone tamp until it fills to the level of the subchondral bone of the adjacent cartilage. And that's what that looks like. And once I have it nice and packed in, I'm going to put fibrin glue on the entire surface and put the membrane on the top. Here we are templating for the membrane. Put the membrane on the top after the fibrin glue is on its surface, and then just flatten it out, and let the tourniquet down. Once the tourniquet's down and everything is dry, we then microsuture on the second membrane and then fill the entire sandwich in between with cells. And then that's what it looks like when you're done. So looking at that, we had 39 patients at 2-year minimum follow-up. So that's not that common. So 659 patients, we had 39 that were sandwiches. And you can see the preoperative diagnosis: osteochondritis dissecans, avascular necrosis, cyst. 4 of those were from prior microfracture, large cystic areas, and 3 were from 2 failed OATs and 1 failed OBI plug. And you can see the ratio of male to female. These are pretty much all surfaces on the knee that we treated, even the tibial plateau. In the classic sandwich, we had 24 patients. In other words, just the entire defect was bone grafted. In the segmental sandwich, we had 15. So when we looked at just the isolated sandwich alone, I'm going to just get to that at the very end. But just here, I'm just going to show you one other example that I think illustrates the usefulness of this. Here's a 23-year-old male, Michigan State University Division I football player. He'd had a previous OATs and microfracture in 2006. He then had a repeat microfracture later that year, and then an allograft to his medial-femoral condyle in 2007. In 2009, he still was not able to return back to play football. He came to me for another opinion, and his presentation was 8 out of 10 pain. He had a hard time getting out of bed. Sports were not possible, and he was hooked on Percocets. His long axial alignment x-rays, you can see, relatively neutral. You can see the cystic change in his medial femoral condyle where his allograft was. And so I used here, we found when we scoped him, he now not just had his medial femoral condyle with 2 allografts in a snowman position that were both delaminating and necrotic. He also had a trochlear defect and a lateral femoral condyle defect. So this is his lateral femoral condyle cartilage going. His trochlear cartilage was gone. There's his 2 allografts. They were both delaminated completely. And this is after radical debridement of both. And you can see here this abnormal dead bone. And once we excavated and took out the entire allograft, we then went ahead, and you can see it's 2 centimeters deep, so it's a big hole. We then go ahead and use autologous bone from the proximal tibia at the osteotomy site and backfill that with cancellous bone. And then we put on the membranes, let down the tourniquet, and then microsuture a second layer and fill it up with cells. So that's what it looks like when you're all done. And that's his immediate postoperative x-rays. And here we are at 6 months. You can see a very nice repair tissue. There's his bone graft, his autologous bone graft. Here's his repair tissue, medial, lateral, and trochlea, filling up quite nicely. He had some Hoffa's fat pad adhesions that were bothering him, so at 1 year, we did this second look scope. Can we just go through this? This is his lateral femoral condyle transplant. We're going to go from lateral to trochlea and then over his medial sandwich. So here we are just going up this. All looks very nicely filled. You can see the clear seam between the native cartilage and the transplanted cartilage. The transplanted cartilage always looks a little bit whiter. Here you can see in the medial side of the trochlea, a little bit immature at 1 year, but here we're getting down into the transplanted sandwich area. It's pretty much his entire medial condyle coming down here, and it looks very nice and firm, a little bit soft at the very back, but he is now about 8 years out and continues to do very well. So the sandwich technique, when we look at comparing my bone grafting alone to my sandwich technique as time goes on, you can see the failure rate with bone grafting alone and the benefit of adding cells. So we had a dramatic improvement with this cellular technique, and even in salvaging allografts with large osteochondral defects. Thank you. So, any questions before Andreas moves on to the allograft talk about the sandwich technique? Yes. So the way Macy, the question is, how has Macy changed the sandwich technique? All it has done is made it a sutureless technique. So what I do with the Macy technique, I still use two membranes, but I face the cells towards each other. So the first, I do the bone graft and debridement. Then I put the first membrane on, then I put a bunch of glue on the surface after I've templated and cut my Macy membrane. So the smooth layer goes down against the bone on the first layer, and then I put a little bit of glue on top of the layer with the cells up. And then the second layer goes down, and they're both underneath the subchondral bone. And then I seal the edges, and after the tourniquet's down, we put the second one down, make sure it doesn't come up, and then we seal the edges and put the second one down. So there's a lot less suturing. That's the only difference. Question? Yeah, I only use autograft underneath the cells so that the whole thing is autologous reconstruction, and the donor site gets the allograft bone, where I took the bone from. Just backfill it. Okay, Andreas, you're up.
Let's see if that works. Can I just plug that into, I make so much fun of Apple, but sometimes it just works better. Can you see if you can get a feed? Thank you. So let's restart. Let's see if that works. And it does. So this is the central trochlear defect that needed some treatment. So mechanically unloading of the osteotomy helps with the medial compartment, but obviously doesn't do anything for the trochlea. So that needed some treatment, in this case with an osteochondral allograft. So step by step, first you put a guide pin into the center of the defect. You need to be perpendicular, which on a femoral condyle is somewhat easy because it's convex and convex. In the trochlea, the patella, it's a little bit more challenging because you have a concavity. So you have a sizing guide that rests on the two edges of the concavity, but proximal distal, that's a little bit up to you. And unfortunately, until better instrumentation is made, you only have your fingers to judge and make sure that you're really perpendicular. So this shows putting the guide pin in that larger sleeve, that's the sizing cylinder that generally helps you get the size right, but also get the alignment correct. Then once you have that, you remount the defect. So you create a recipient side. You want to make sure that you don't get any heat necrosis. So you always see a bulb syringe with saline whenever there's cutting or reaming. And as mentioned before, you want to keep the composite thickness pretty thin. Now again, because this has a convexity on one side, so proximal to distal, but a concavity going medial to lateral, that is not a plug that will have the same thickness throughout. So proximal and distal, it'll be thin, and medial and lateral, it'll be thick. So it almost looks like a saddle. Then once you have reamed, then you check the depth. So check it in all four quadrants, and then you want to transfer that over to your allograft. So this is an allograft trochlea that is both side specific but also size matched. The size matching goes off the tibial width, and then you find the corresponding place on the graft. So this is both the same sizing guide that you saw me use before to put that central pin in the recipient, and then that black sleeve is a cutting guide. You put pins, there are different systems, but in this case you put pins into that black drill sleeve or a reaming sleeve to fix it onto the allograft itself. And then you take your sizing cylinder out, you fix it. That's a coring reamer that goes in. And here comes the bulb syringe again, because you don't want to heat this up because chondrocytes are pretty sensitive to temperature. Anything more than about 50 to certainly 60 degrees and your chondrocytes start to die. Once you have done your coring reamer, apologies, you do a countercut at the base. And if you do it the right way, that graft will just pop out. And there you have that little plug, and you can see how it's shaped almost like a saddle. So that now needs to be thinned down. The measurements that I had taken before now get transferred to the graft. This is something that I started doing a couple years ago. We're starting to do a study on that as well. So trying to replace the donor bone marrow, which is immunogenic, with recipient bone marrow. So this is just an aspiration of bone marrow. And this is not bone marrow aspirate concentrate, so I don't need 100 cc's or 150 cc's to concentrate back down. This is really just 4 or 5 cc's, just enough to flush that subchondral bone. And it goes through the incision, either through the proximal tibia or the distal femur, so you don't have to prep out the iliac crest. There's a little bit of heparin in the syringe so that it doesn't clot right away. You pull, and you really only need 4 to 5 cc's. And some studies have shown that really the first few cc's have the highest concentration of stem cells anyways, and anything after that is really more blood that you pull into the defect. So if you want more volume, then you have to reposition your needle and go to new donor areas. Otherwise, you end up with mostly blood. This is a plug after it's been shaped. So again, you can see that it's for a trochlea, shaped like a saddle. So the two sides, left and right, are high, and up and down, those are the proximal and distal aspects of the plug, are thin. Then you pulse lavage to remove as much bone marrow from the plug as you can, and then I just seed or flush the recipient plug with the bone marrow that we just aspirated. So flush that a few times, try and get as much autologous bone marrow into the plug as you can. This shows you the hole now, created through the coring reamer in the recipient. And then again, you don't want to hit these things, so ideally you want to just gently rock that into place and then push. If it's in a femoral condyle, you can actually use just range of motion of the knee to get it seated all the way. In the patellofemoral joint, that's a little bit more difficult. You can revert the patella and range. That can help you. Most of the time, with the new instrumentation, the clearance is such that there's like a scratch fit. So you can push it in, it meets resistance, but you don't have to use a mallet that you really want to avoid as much as you possibly can. And then at the end, that's a different patient because we got better pictures of this one. You can match the surface topography pretty well with this, both looking along the trochlea coming from above or just straight on. And if you get an MRI scan, and currently I do that at 6 and 12 months for every patient, that's a 6 months MRI scan. So you can see that the signal in the marrow is still dark. That means it's not completely replaced yet with autologous, but the surface contour of the cartilage matches pretty perfectly. So it's not something that I would choose to be your first or even the 10th osteochondral allograft that you do, just because the patellofemoral joint, the anatomy is so much more complex. But once you get comfortable with doing femoral condyle osteochondral allografts, you can expand that into the patellofemoral joint. And patients really recover pretty rapidly from this because the surface is set, just the bone needs to heal. And in comparison to cell-based, that's a little bit quicker recovery. But as I said, it's challenging to get a graft that fits. Sometimes patients wait for months to get it, and technically, it's a little bit challenging. Thanks very much. Questions? Just allografts in general. Or probably we have enough time to have questions about the whole day. Mm-hmm.
It looks like there's not a lot of questions at this moment, so I'm thinking, why don't we may have an executive decision here and just have questions over a glass of wine outside? Yeah, I think that's good. Okay. Thanks for a great first day.